So good morning. I, Chair Shelley Bailey, call the Oregon Prescription Drug Affordability Board meeting on October 15, 2025 at 8:02 a.m. to order. Melissa, if you could please call roll.
Chair Shelley Bailey.
Present.
Vice Chair Amy Burns.
Present.
Dan Hartung.
Here.
Lori Hoagland.
Present.
Dan Kennedy.
Present.
Michelle Coder.
Present.
Chris Lehman. He's not here yet. We'll let everyone know when he arrives. John Murray.
Here.
We have a quorum.
Thank you, Melissa. And for the record, if you see Board Member Lehman enter the room, if you could please just interrupt and announce that, I would ask him to announce. I'd appreciate it. Thank you. So I would now like to welcome everyone to today's meeting. We do have an American Sign Language interpreter with us today, and please use the Zoom controls to access the interpretation channel. And we'll pause for a moment because I know that sometimes we share information on how to, there we go. So we share information on how to access the interpretation channel here on our screen right now. So this morning, our board meeting begins with a conflict of interest declaration, which are stated each month according to board policies. Do board members have any declarations of potential or actual conflict of interest? Have board members met with entities or individuals related to board activities? And have board members provided testimony about to the Oregon legislature about prescription drugs? So I do see that Board Member Murray has his hand raised. So Mr. Murray, you have the floor.
Thank you, Chair Bailey. The usual statement, please. Under advisement from the Oregon Government Ethics Commission, I declare a potential conflict of interest due to my ownership of Murray Drugs Incorporated, comprised of 3 independent pharmacies in Eastern Oregon that have pharmacy services contracts with PBMs, insurance companies in the state of Oregon. Thank you.
Apologize, I was on mute. Since I see no other hands raised, I will go ahead and discuss the approval of minutes for the August 20th, 2025, as well as the September 17th, 2025 meeting minutes. So the board is going to begin approving the minutes by general consensus. This is allowed under Robert's Rules of Order, which the board has adopted into its policies and procedures. We begin with the minutes from August 20th board meeting. The 8:20 minutes were carried over from last month because the motion failed due to 2 board member absences. So I would like to ask board members if anyone has any changes to the draft minutes from August 20th, 2025 that they would like to put forward right now. So with me seeing no modifications to the minutes, do we have a motion to approve the August 20th, 2025 meeting minutes?
This is Chair Kennedy. I so move.
Okay.
And I will second. This is John.
Okay, so since we have no corrections, it looks like the minutes are approved as corrected. Melissa, do we have to vote on it or?
No, we do not take a vote.
We already discussed that.
Yeah.
Okay,
Right.
so we have a motion and a second to approve the meetings as we set forward for August 20th, 2025. So now we will move on to discussing the meeting minutes from September 17th, 2025. If there are no corrections to the minutes, does anyone have any corrections to the minutes as presented? So with there no suggested changes to the minutes, I apologize for the audio on my computer. The minutes are approved as corrected. And so Melissa, that's our modification because we follow Robert's Rule of Order. If there's no changes to the minutes, we don't have to vote on it and we can just approve the minutes and proceed. Is that accurate?
That's correct. You do not need a motion or a second either.
Okay.
You can just approve by consensus.
And for everyone listening in, we reminded board members of the Robert's Rules of Order so that when we're approving minutes, we take into consideration if board members were absent. So we will not be voting on the September minutes because we did not have any suggestions to modify the minutes. So we are now moving on to the program update. I would like to introduce the new board member, Michelle Coder, and provide a bio to everyone here today. So Michelle Coder is our new board member. Welcome, Michelle. And she is the pharmacy director for the Multnomah County Health Department, a federally qualified health center. She was appointed by Governor Kotek and confirmed by the Oregon Senate on October 1st. She has experience in budget development, management, clinical pharmacy services, Medicaid managed care. Ms. Coder served on the Oregon Pain Management and Oregon Health Resources Commissions and OHA's Viral Hepatitis Planning Group. Previously, she was the Assistant Director of Pharmacy for Care Oregon and a clinical specialist for Medicaid programs for Oregon State University. Ms. Coder holds a doctorate degree in pharmacy from the University of Rhode Island and did her residency at OHSU. So, Michelle, welcome. I also would like to introduce to everyone here today our new executive director of the Prescription Drug Affordability Board and Drug Price Transparency Program, Sarah Young. Sarah has directed the Policy Research Division of the Federal Office of Rural Health Policy in the Health Resources and Services Administration since 2023, where she managed a division of 17 people. Sarah's past work has included managing rural health clinic COVID-19 response programs, analyzing rural hospital and critical access hospital policy, tracking nationwide rural hospital closures, and coordinating the Medicare Rural Hospital Flexibility Program focused on improving quality of care and operational efficiencies. Sarah was born and raised in Eastern Oregon and holds a master's degree in public health from Portland State University. So welcome, Sarah, to our program. Moving forward in the agenda, we are now in the public comment period for general public comments. Later in the meeting, we will have public comment time about specific prescription drugs under review today. For the general...
Chair
Go ahead.
Bailey, excuse me, would you like me to give a brief PDAB
Yeah.
program update?
I sure would. Yes, it would be nice to hear a program update. So thank you very much.
Sorry for interrupting. And I want to again say thank you, Chair Bailey, for that introduction, and good morning, members of the board and of the public who are joining us today. I'm really excited to be here and to be working with this board and staff. This is just my 8th day on the job, and I'm really looking forward to learning from all of you. As you could tell from my bio, I have extensive experience in rural health, care policy and issues, and I look forward to bringing that to this group as well. I also want to second Chair Bailey's welcome to Michelle Coder as you join the board. As your staff, we are really here to help you, so please let us know how we can assist you in your role on the board, and please reach out anytime. As always, the PDAB and DPT teams have been working hard. We have the annual public hearing on prescription drug prices for the Drug Price Transparency Program scheduled for December 4th. Please save the date on your calendar if you are interested in attending that hearing on Zoom, and there's more information available on the Drug Price Transparency Program website. For PDAB, the annual legislative report is in development, as we've previously discussed, and that draft will be one of the focuses for discussion at the November board meeting. And today's board's policy options discussion will help inform that draft for next month. As a reminder, the annual report will review price trends, the drug subset list, policy recommendations and PDAB updates, and then this is a separate report from our drug review report that will be finalized in March. Finally, we have included the 2026 PDAB board meeting dates in this month's meeting materials, so scroll to the very end of this month's meeting packet if you would like to add those dates to your calendars. Look forward to having you at future meetings. And with that, Chair Bailey, I will turn it back to you. Thank you.
Thank you. I do apologize for everyone listening in about the notifications that come through on my audio. I am working on amending that. So, Sarah, thank you very much for the program update. We are moving to the portion of our agenda related to the public comment period for general public comments. Later in the meeting, we will have public comment time about the prescription drugs under review today. For general public comments, the board received 15 letters, which are posted on the board website. I am going to take a moment to recognize the letters that we did receive before I invite the individuals who asked to provide oral testimony here today. So the letters that we received for this month's meeting are from Kelsey Level from Novo Nordisk, from Michael Turchetti from Eli Lilly and Company, from Jennifer Taylor, a patient, from Mark Jackson, Bridge Pamoja, from Olivia Bacchus, the Aimed Alliance, from Diana Grove, patient, from Daria McGrew, pharma, from Carissa Kemp, Sanofi, 2 letters were received, from Melody Calkins, bio, Carl Schmidt, HIV Hepatitis Policy Institute, John Mullen, Christy Marcotte, Charlie Fisher from the Oregon Coalition for Affordable Prescriptions, Tiffany Westrick Roberson and Vanessa Lathan, each and PIC coalitions, from Rainier Simmons and Jen Law, CAN, from Dr. Harry Gawanter, Let My Doctor Decide Network, Action Network, and from Marianne Cooper, Regents Blue Cross Blue Shield of Oregon. So thank you for everyone who provided those letters. Again, they are posted on the board website. I will now move to the individuals who requested to provide oral testimony today. The board received 6 requests to speak. I will call on the individuals who signed up to speak and ask them to state their name and organization. As a reminder, each individual has 3 minutes, and we will have a timer visually represented as you speak. The board will not deliberate on issues or requests during this time. So the individual I have first written on my list today is Jennifer Taylor, who is a patient. So Jennifer, if you are here, welcome, and you have the floor.
Chair Bailey, I do not see Jennifer Taylor in the meeting, but if Jennifer is here, if they could raise their hand and let us know, we could maybe call on them later.
Absolutely. If you
Yeah,
can check
thank
for
you.
those hands raised, Melissa, I'll move on to the next individual and we'll circle back with Jennifer Taylor.
Okay.
The next individual on the list is Jessica McBride from the Oregon Coalition for Affordable Prescriptions. Jessica, if you are here today, welcome, and you have the floor.
Good morning, and thank you for the opportunity to comment today. And also want to extend a warm welcome to Michelle Coder and Sarah Young. My name is Jessica McBride, and I'm here on behalf of the Oregon Coalition for Affordable Prescriptions, or OCAP. And we represent Oregon families, seniors, and young people who struggle every day to afford the prescriptions that they need. We believe that every person deserves to afford their prescriptions and understand how drug prices are set without needing an advanced degree. For transparency, our organization does not accept pharmaceutical industry funding. The Oregon PDAB was created to protect Oregonians and our healthcare system from high prescription drug costs, and that mission is more urgent than ever. In 2024, the Oregon Health Authority spent more than $1 billion after rebates on prescription drugs for Oregon Health Plan patients. In the same year, over 50,000 OHP patients delayed filling a prescription because of costs, and more than 45,000 skipped or reduced doses to make medication last longer. Meanwhile, we also have the federal cuts from H.R. 1, or the Big Beautiful Bill, already rippling through our economy. The state economist recently projected a $641 million drop in revenue due to those cuts. Rising drug costs and shrinking federal support mean that Oregon will have to do more with less, especially for our rural and low-income families, seniors, and people with chronic or rare conditions. When medications are unaffordable, Oregonians pay the price. That's why your affordability review work is so vital. High-cost drugs don't just endanger patients' health, they also drive up insurance premiums and state health spending, taking dollars away from our communities and from small businesses. We urge you to look at other states for guidance. This month, on October 3rd, Colorado's PDAB became the first in the nation to set an upper payment limit for a drug, Enbrel, aligning its price with Medicare's maximum fair price. The move is expected to save Coloradans and their state government millions. Lower prescription drug spending means more money in paychecks, more stability for small businesses, and fewer premium hikes for everyone. There's a lot of talk about accessibility, and I want to emphasize that medication is not accessible if people can't afford it. Your decisions can set in motion real relief for Oregonian patients, and lasting savings for our overwhelmed healthcare system. We urge you to reach consensus on robust affordability reviews and to recommend strong policies that protect Oregonians and our healthcare system from the high cost of prescription drugs. Thank you.
Thank you for your time. The next individual that I have signed up here to provide testimony today is Daria McGrew from Pharma. Daria, if you are here, welcome, and you have the floor.
Good morning, Chair Bailey, members of the committee. First, welcome, Dr. Coder and Executive Director Young. We look forward to working with you in the future. This is, for the record, Daria McGrew on behalf of Pharma, the Pharmaceutical Research and Manufacturers of America, representing America's innovative biopharmaceutical companies. First, the proposal in the policy recommendations to seek an exemption in the public meeting law from allowing media and executive session is a positive step, first step in the right direction. As we have previously commented, there are additional steps needed to adequately protect confidential, proprietary, and trade secret information, but this proposal is moving in the right direction and appreciate that. We support the board's consistent efforts to seek transparency and reform across the supply chain in order to address affordability of medication for Oregonians, rather than pointing fingers at only one aspect of a complex supply chain. Previous efforts of this board have increased transparency on PBMs and health plans, and suggestions from the board members continue this work. We support policy recommendations that account for the wide array of factors in the supply chain that impact affordability, such as those recommendations that require health insurance companies and PBMs to pass rebates to patients at the pharmacy counter, delinking PBM fees from the price of a drug, and increasing PBM transparency. Next, again, thank the board and staff for creation of the new data dictionary and changelog for the scoring rubric. This is a good best practice in work like this and should be extended to the entire review packets rather than just the rubric. I encourage continued revisions and corrections. There are some aspects of the changelog that don't seem to match what is still in the rubric, and there may be some version issues there. And as in the past, due to the board's shortened time frame for submission of written public comments, we will be submitting more detail in these comments in written form in subsequent weeks. Thank you for your time.
Thank you, Ms. McGrew. The next individual I have signed up to provide testimony is Lauren Sant from Caring Ambassadors Program. Lauren, if you are here, good morning and welcome, and you have the floor.
Good morning, Chair Bailey and members of the board. I'd like to welcome Sarah Young and Michelle Coder. We look forward to working with you and to reduce the cost of healthcare for all Oregonians. My name is Lauren Sant. I'm the Executive Director of the Caring Ambassadors Program, and we've been empowering people to be advocates for their health since 1997. I know the rules require you to consider affordability of insulin drugs. However, given subsequent changes to the reduction of copays to $35 or less for patients, I don't see how it creates an affordability question unless you're only looking at the cost to the state. Not to mention, once a person with diabetes finds the appropriate treatment, they must have access to the ones that work. So hopefully today's reviews will be quick and short. As mentioned earlier, the impact of HR 1 is coming fast, and the consequences for Oregonians are going to be severe. People across the state have devoted considerable amount of time and energy to the Prescription Drug Affordability Board. However, this effort has not yielded any savings to our healthcare system thus far and is unlikely to do so in the future. It's not a failing of this board. It's proving difficult in every state that has adopted a PDAB to reduce out-of-pocket costs for drugs for its constituents. The board should consider either disbanding, as suggested Dr. Burns, or requesting an expansion of its scope to encompass more than just drug costs and utilize its collective expertise to assist the legislators in navigating the changes coming, thereby minimizing disruptions to Oregonians living with chronic diseases. The fact that the insurers and the advocacy organizations they fund don't want you to look to the entire supply chain speaks volumes. Insurance plans dictate affordability, as shown in the Each Pick survey, which has been posted multiple times. Study after study has indicated that setting price controls will not reduce out-of-pocket costs for patients. I really appreciate all of the suggestions that you have for the legislators. I hope that you continue to work through those today and make positive changes. I appreciate all your work. Thank you very much. Have a great day. And again, welcome to Michelle and Sarah Young.
Thank you for your testimony. I do want to now recognize Auden Friedman from Augsburg. Auden signed up to provide testimony. So Auden, if you are here, welcome and you have the floor.
Thank you. Dear Chair Bailey, Vice Chair Burns, and PDAB members, thank you to the board for your work on behalf of Oregon patients and the healthcare system. I also want to welcome Michelle Coder and Sarah Young to the board. My name is Auden Friedman, and I'm a campaign associate with the Oregon State Public Interest Research Group, or OSPIRG. OSPIRG is an advocate for consumers for their safety, health, and fair treatment. In healthcare, OSPIRG is an advocate for high-value care. Too often, consumers pay high prices but don't receive higher quality of care. OSPIRG, through grassroots campaigns and with the help of over 30,000 supporters in Oregon, seeks to cut healthcare costs which do not pay dividends in quality. OSPIRG is also a member of the Oregon Coalition for Affordable Prescriptions, or OCAP, and we share their sentiments today. We support the PDAB's continued efforts to fulfill its mission, to protect Oregonians and our state's healthcare system from the high cost of prescription drugs. We need the PDAB now more than ever, as the Oregon healthcare budget shrinks due to federal policy changes and large premium increases are predicted. We must face the problem of cost. The healthcare that we all need to live happy and fulfilling lives is increasingly being priced out of our reach. Prescriptions are a glaring example of this. According to the Rand Corporation, we pay 2 to 3 times as much as other OECD countries for the exact same drugs. This affects everyone: individuals who pay out of pocket for high-priced drugs, patients who see their insurance premiums rise, and all taxpayers. That is why the work of the PDAB is so important. The affordability reviews that the PDAB conducts are important first steps in understanding where there are harmful excess costs in the market. And that is valuable information. But even better than information is informed action, like Colorado's PDAB took in setting the first in the nation upper payment limit on Enbrel. The Colorado Consumer Health Initiative estimates that this UPL will save Coloradans $32 million a year. In Maryland, the PDAB approaches a UPL decision on diabetes drugs Jardiance and Farxiga. To echo county officials who urge the Maryland board to move forward with UPLs, drugs don't work if people can't afford them. Today, the board will make legislative recommendations. We strongly encourage PDAB to empower itself with a tool to fulfill its founding charter, UPL authority. Oregonians are still burdened by the cost of prescription drugs. The PDAB, and particularly its potential UPL authority, is still one of our best hopes for cutting into the glut of unnecessary cost in healthcare. We ask that the board follow the example set by Colorado in making bold and necessary strides to lower the cost of unjustifiably priced prescriptions. Thank you for the opportunity to comment on this very important issue.
Thank you for being here today. The next individual that we have signed up to provide testimony is Dean Soar from the MLD Foundation. Dean, welcome. And if you are here, you have the floor.
I am here. Good morning, Chair Bailey and committee members. My name is Dean Soar. I am co-founder of MLD Foundation for Metachromatic Leukodystrophy. I'm a rare disease father. 2 of my 3 kids have this disorder, and a long-term Oregonian. Thank you all for your service. MLD is a rare disorder, one of over 10,000 that collectively affect 1 in 10 Americans. That's 35 million Americans, 4 million of which live in Oregon. It's these people that I represent today with these comments. For MLD, we had an FDA-approved therapy in 2024. It took 19 years for that therapy to get through the process, not at the FDA, but through all the research and then through the FDA. The therapy is, and I'm air quoting, I don't know if you can see me or not, is curative when given pre-symptomatically. And that's really important. We have newborn screening coming to identify those patients. But a curative therapy means that there's no ongoing costs from the disorder. Many of the drugs that you're talking about here are clinically prescribed, and they're ongoing costs. Your charter, the Prescription Drug Affordability Board, is established by statute to protect residents of Oregon's governments, health plans, healthcare providers, pharmacies, other stakeholders within the healthcare system from the high costs of prescription drugs. Further, the board is directed to collect and evaluate information concerning the cost of prescription drugs in Oregon, perform affordability reviews, lower the list price of prescription drugs, and then make recommendations to the Legislative Assembly to make prescription drugs more affordable. There is nothing in your charter about value, efficiency, or benefit to the patient. This is backwards thinking. Value must be your first priority. When we have high value in our system, high performance, high efficiency, we will get better results, and they will show up both in the health of Oregonians as well as in what it costs to have Oregon's healthy. Cost is not just price. Recent studies have shown that upwards of 50% of the cost of therapies is paid to other than the drug company. If you only pull the one lever, upper price limits, or how you do that, and say, we're just going to lower the cost, that doesn't fix all of the other problems. There's a difference between a fast food meal and a healthy sit-down lunch. A healthy lunch is focusing on value, not just cost, typically be a little more expensive. But it's not just today's cash flow, it's tomorrow's healthy citizens that are most important for all of us. Please be careful. Upper price limits are price controls. They look like fast food, prioritizing the short-term savings and dollar signs over long-term healthy patients. Some other levers: efficiency and role of PBMs. PBMs that benefit from higher prices, they're paid on a scale, are not looking out for the state, the payers. They're not looking out for the patients. They are middlemen, and they could restrict supply. We need to have processes that give us better access to optimal therapies, and again, lowering out-of-pocket costs so that patients can afford their drugs and will be incentivized to take them. Thank you for your time. I look forward to working with you and with the state legislator to add value to your charter.
Thank you for being here today. We are now moving to the portion of the agenda related to the continued discussion of policy recommendations for including in the 2025 annual report. So last month, the board discussed policy recommendations submitted by individual board members. Today, the board will continue this discussion. Next month, the board will vote on policy recommendations to include in the annual report submitted to the Oregon legislature in December. So Courtney Whitlock, if you could help us facilitate this continued discussion, I would appreciate it. I also do want to make an announcement for the record that I will be leaving the meeting today at approximately 10:20 a.m. Pacific. We also intend to take a break around that time, and after the break, Vice Chair Dr. Burns will help facilitate the remaining portion of the meeting. So Courtney, you have the floor to help us with our continued discussion related to board member suggestions related to legislative recommendations.
All right, thank you, Chair Bailey, and good morning, board. I'm going to take a moment to share my screen so we can have this conversation. Again, this is just a recap and a continuation from last month's discussion on policy recommendations. If you recall, I set up the recommendations following through what the prior year recommendations have been, and I hope everyone has had the opportunity to go back and review those. I've indicated some stars in the material packet for this month, just kind of indicating that there's similar intentions with prior recommendations, as well as within this year's recommendations that are similar between the board members who provided recommendations. So they kind of go through, the colors are just kind of like the matching, and I apologize for anybody who may not be able to see those colors. We can have further discussion on what those represent. So beginning again.
Sorry, Courtney, before we continue this, I did want to recognize for the record that I believe that Mr. Lehman has joined the meeting. So just for the record, it's my understanding that Mr. Lehman is now in the meeting.
Thanks, Chair Bailey. Sorry I was late.
No problem. And Courtney, I apologize for interrupting you.
No worries. So kind of following back to John Murray's suggestions for the 2025 policy concepts. John, are there any recommendations that you would really like the board to lean into to have a discussion, or any that should be removed that won't be beneficial for a vote on for next month?
Thank you, Courtney. Yeah, after some thought about last month's meeting, and I have an example I want to explain of maybe something I don't understand, would like to understand, of spread pricing and how it ripples through the system. My suggestions for policies, just briefly, though, first is I've kind of modified it. One of them is exemption from public meeting laws for trade secret laws, if that's possible. Oregon is a very transparent, seeking state, so it might be a stretch to achieve that. But I think it would further the ability of this board to look into what really happens in transactions. I still would heartily recommend expanding the scope of the board. It was inferred that maybe we aren't the right people to look into this. And my next suggestion might address that a little bit, but I think we are actually. The next one is I suggested quite a few changes that specify specifically to PBMs and the drug delivery system at a level of pharmacy and plan and things like that. My biggest suggestion, though, of having a single PBM for Medicaid and CCO patients in Oregon, I would like to change that just a little bit. We have a short session coming up, which means nothing will get done. Legislators have two bills. They'll be strapped for time. 27, however, we have more time. It's a longer session. I would like to change my recommendation of just flat making a recommendation to have a one PBM to forming a work group through the summer of 2026 to study the concept of having one PBM for this, what my suggestion is, but only form the work group. It would bring all people to the table. We could bring experiences from other states. We could bring plans, PBMs, pharmacies, everybody to the table to discuss it in a very transparent and open way. Oregon is very fortunate to have a system maybe already in place to handle this. And so if we just make a recommendation that, from the PDAB that we have one PBM, I think it could get swept under the rug. If we form a work group, I think it would go further. And I think discussion would be robust. I have legislators reaching out to me in Heppner asking, does this PBM's claim to be helping you on this particular program, is it really helping you? Or what can we do to help you stay in business? Personally, I think they're embarrassed by having the rank of #1 least accessible to pharmacy care, local pharmacy care in the nation. Well, lower 48. I think that if we did that, I think we would go a long ways towards furthering the policies. If the PDAB was allowed to study other things, and that would be a recommendation I'd love to see in place and passed in the 26th legislature, and we're talking to legislators now privately. I would love to see that so that we can bring some of these things forward. I also, I'm putting here a recommendation about UPLs. Again, I'll put it in words. I'm not a fan of UPLs yet because I don't know how they're going to ripple through the system. I worry about just attacking one part of the cost of the medication without addressing all the other areas where it goes. I'm sorry I'm taking so long. So truth is stranger than fiction. Last month's meeting, one of my pharmacists from one of our stores called me and said, hey, I have an interesting thing for you. Wasn't solicited, wasn't just happened to be that day. An example of spread pricing. So I've got a pharmacy transaction detail from a patient that brought it in that said that their insurance company paid, I'm assuming it's to the PBM, $113.16. They wanted to know, did the pharmacy get any of that? So we go to our pharmacy system. And we get transaction detail from on each prescription, patient pay segment, ingredient cost, dispensing fee paid. The patient pay amount was $25. That was our copay. Ingredient cost paid on this generic ADHD medication, $24.90 was ingredient cost paid. My dispensing fee was 10 cents. The true cost of the medicine was $4.89. So if the patient paid $25 and the plan paid $113, that's a difference of $88.16 that the plan paid the PBM for a med that costs $4.89. I need an explanation. Here's where I don't understand, as Vice Chair Burns said last month. Where, and as people have testified to the legislature, we need spread pricing to pay our PBM bill. Please tell me how that benefits the patient in Oregon. And I'll just leave it at that. Thank you.
Are you addressing me?
I'm addressing anyone that can answer this question about PBMs. I don't understand.
Well, I don't work for PBM and I don't have anything to do with spread pricing. So I would appreciate that you don't address me in that sentence because I don't know anything about that.
Okay, fair enough. Thank you.
And Chair Bailey, I see your hand up.
Oh,
if you want.
Thank you. I mean, leaning in and listening to the comment that Mr. Murray just shared, it did remind me of the recent California law that I believe passed this week that does eliminate spread pricing. That's in the commercial markets. But some of these examples that Mr. Murray just kind of provided, the real world examples, I think even just showing, drivers that impact affordability, and that's both patient affordability as well as affordability to, the system. Even the state of California passed a law this week that addresses a lot of those things. I know it's not enacted yet, but it will be soon. But Dr. Burns, I see your hand is raised. So
yeah, I just want to let John know that Oregon Medicaid doesn't allow for any spread pricing. It's actually required to be a pass-through. So if that's happening in your area, you should report it to the OHA.
Mr. Murray, your hand is raised.
Yeah, this isn't an Oregon Medicaid claim. This is a commercial claim, but it's an example of what was testified to at the legislature and valued by the plans in Oregon. No, I'm actually suggesting the opposite. I'm suggesting that we do encourage the legislature to look at a 1 PBM plan for Medicaid and CCOs, not just what we have now. And I understand
you're talking about pass-through and spread pricing and PBMs, and you mentioned my name. I just would like you to take that out of your mouth. Yeah.
Fair enough. I will do that. But we understand more than was implied at the last meeting. So this group does have knowledge of what happens in the marketplace. And looking
but you're talking about commercial, you're like giving a commercial example, but you're talking about Medicaid. So you're mixing up the two things and you're making it sound like that's what you're talking about.
The Medicaid example, if we were to encourage the legislature to form a work group, many of these recommendations that I made, for example, would happen. You're exactly right. Many of these things, these suggestions that I made, like number 9, objective definable cost or verifiable cost figure, increase PBM transparency, eliminate spread pricing, delink PBM fees, all those things would happen. So yes, I guess I'm speaking for both. I don't like what I see in the commercial market or any of the markets where spread pricing occurs. So yes, I am talking about two different things, Amy.
Great. Just don't name check me in that. Thanks.
Thank you for clarifying for the record, Mr. Murray, that essentially you were giving 2 examples, right? One was a real world, spread pricing example that your store sees in the commercial market, as well as your, I guess, new recommendation related to the work group to look into what something might look like related to a single managed Medicaid plan for all. Am I hearing you right related to those 2 comments?
Yes, exactly. Thank you.
Okay. Thank you very much for clarifying.
So kind of leaning back into you, John, and the rest of the board members, we appreciate, John, this kind of the clarification and of the recommendations. is there anything within John's recommendations that the board feels that should be part of the vote for next month, or take that recommendation of what John had mentioned to maybe make one recommendation around the study of one PBM through the system? But I guess before anybody answers, I'll turn to Dr. Hartime.
Yeah, I generally, I think, support the John's revised recommendation to kind of roll up. He's got, a bunch of different concepts here, and some of them are shared across other board members. And I think I would generally support kind of rolling all those up because, our charge is affordability, and it's clear from the foundational legislation that it's about, identifying affordability challenges at the drug level. I mean, it's pretty clear. And, it recognizes the stakeholders that are involved in this and the multifactorial issues involved in affordability. But it's pretty clear that the intent is around the drugs themselves. And so to that end, I think, these very specific concepts or points about, transparency of the PBM and making sure that reimbursement is based on acquisition costs and things. These are very, very specific things and very complex. And I think I would support rolling them all up into some sort of working group. And I also recognize what John's getting at in terms of like the fragile pharmacy system in the state. And we do have big access issues, and we've had closures are definitely a thing that's happening not only in Oregon, but across the country. And so I think, that recommendation, I think, recognizes that is a critical issue that, we need to kind of keep our eye on. But in terms of, the specificity of our recommendations, given especially, I guess, the short session, I think, try not to be long-winded here, but too late for that. But I think rolling them up into a larger recommendation to study this issue and making sure that someone puts forth some sort of larger policy recommendation for maybe the larger session, I think makes sense to me. I'll stop.
Thank you, Dr. Hartime. Dan Kennedy, I see your hand now raised.
Yes, I just wanted to, I wanted to second John's ideas of having a work group to convene at the end of the short session to work out some of these larger details, including the scope of PDAB. And perhaps we need to expand our scope, because I think affordability and accessibility do go hand in hand. And if there's no pharmacies available, it doesn't matter if the medication is inexpensive or expensive if there's no place for the patient to get them. So I like John's idea.
Good. Chair Bailey, did you want to go or give Michelle an opportunity?
I'd like Michelle to have the opportunity, and then I'll go after that.
Michelle.
Thank you, Chair Bailey. I want to also put forth my support for, creating a work group that takes a deeper dive into the drug delivery system. My question is, and this is specific to some recommendations for 2026 legislative session, is if we do create a work group, do we have the information available to us to really make informed decisions? And so does that also need to be part of a legislative recommendation?
Chair Bailey, do you want me to answer that, or do you want to?
You go ahead and answer that, and then I'll provide a comment.
All right, so this is a high level, Michelle. For this recommendation, what we do is we provide the concept to the legislators, and then they would provide us direction, or they would assign the study to be with a different committee within the legislation, or they would assign it to a different maybe division that may have that capacity. So just because we make the recommendation doesn't mean that PDAB members themselves would be that work group. So hopefully I answered your question, but again, support what you're saying about the group and the study of the delivery system. And back to you, Chair Bailey.
Thank you. So while I don't disagree in concept with Mr. Murray, I do feel that making a recommendation to the legislature for a work group is a little bit of deflecting the challenges that we have at hand. We do, if you look at Senate Bill 844, we do have the ability and authority to make recommendations for policies that impact list price of prescription drugs sold in the state. And I do believe that one of the pieces that does impact affordability are PBMs. So, the state of Maine has made recommendations in their annual report to the legislature related to expanding their scope. New Hampshire made suggestions related to biosims. Washington State also made recommendations related to expanding the scope of PDAB. While I don't disagree with my colleagues that, a work group could be helpful, I also feel that we do have the right people on the bus to make legislative suggestions. And I don't want to see some of these things that both Mr. Murray provided as well as other members essentially die because we suggest a work group. So in my personal opinion, I believe we do have the authority to make legislative suggestions and, clearly want to just continue to discuss all of the concepts that board members have. But I see that Michelle has her hand raised. So Michelle, you have the floor.
Yeah, thank you. Just for additional clarity about my statement, it was really about whether the information is publicly available. And so I think there are some limitations with the APAC data and some of the other data that this committee has. And so that's really where my comments are centered around.
Thank you for clarifying. Mr. Murray, you have the floor.
Thank you. Yes, I understand your comments, Chair Bailey, about the policies and maybe the vote will show that, we suggest a work group, but these are concerns that the PDAB had in specificity, because should something like the Ohio PB or the Medicaid plan go into effect, I think it would take care of most of these. But to say that there are concerns to the PDAB, I think maybe it's worth voting, and we put it as a bullet point underneath the possibility of a work group studying those things. I fear that if we make specific recommendations, they're pretty easy to shoot down in legislative hearings. But a work group where all people can come to the table. We want to hear from everyone. We want to draw an experience from other states. And they're going to be hard numbers. They're going to be exactly how things were done and how it might fit in Oregon, even though we have part of the mechanism in place, in my opinion, which might make it easier. If there's cost savings and it increases access, fantastic. So anyway, I still would like to suggest, though, that we expand the scope. I'd like that to be one of the things that we recommend, expand the scope of the PDAB board for discussions that we can have in our board. And if the work group happens, fantastic. I think it will, if it was suggested. I don't mean to pivot from this point, but I really would like to hear Dr. Hartung's thoughts on the 340B suggestion that he put out there, if we could, please, sometime in our discussion.
Well, and the good news is we have lots more pages of board member comments, but Mr. Murray, thank you for clarifying that you made that as an additional suggestion, is I guess what I heard for the record, but that I guess, and then as a reminder to all the board members here today, we will be voting on these recommendations in the November meeting. So, Mr. Murray, thank you for that clarification. And then Ms. Coder, just as a follow-up to your comment related to APAC and things, I do want to reference that you are correct that we do have limitations in some of the data that we have, but staff has certainly worked very hard to provide us with data, and there will be a time where we have to lean into the best available data that we have, and that we are continuing to work to improve things throughout the process. So Courtney, I know there's many other policy recommendations, but you have the floor.
Yes, thank you. John, again, appreciate all your information. And I would like to ask you, just because there was updates to your recommendations, if you could email me kind of the concept that you were thinking about so I can add it into the vote presentation for next month. So that would include the one for the study. And then we'll focus on your request for the expansion, that number 10. But Dr. Hartung, if you could kind of elaborate on your suggestion to audit the 340B entities, we'll turn over to your suggestion for the recommendations.
Oh, yeah. So, my suggestion was for Oregon to move in a similar direction as a few other states, most notably Minnesota, and then I believe there may be one or two other states that have started to look more carefully at this, but the 340B program, which has expanded to become quite large over the last decade, with not a lot of transparency around kind of the revenue that's generated by different healthcare entities through the 340B program. And so several states have pursued and undertaken kind of audits of those systems to better understand how much revenue is being generated by different 340B entities, in what types of drugs. The Minnesota audit had some limitations in terms of just looking at pharmacy dispensed products, but I mean, a big driver is also infusions and things like that. And so getting a better view on that. And then there's also issues around how it intersects with the Medicaid program in that drugs that are dispensed to Medicaid patients who in 340B, there's basically prohibitions about collecting rebates on those dollars. And so there's some questions about, if 340B is getting the entities are getting those discounts and the state is kind of foregoing the rebates on those. And so just getting a better understanding of how much rebate the state is foregoing for 340B drugs dispensed to Medicaid patients. So it's very complex. I'm not an expert on it, but I've just been reading quite a bit about it in the last 6 to 12 months. And I think that, putting a recommendation for Oregon to proceed in an audit of these programs or a report about these programs, I think would be helpful. So that was that's the basis for my recommendation.
And Chair Bailey, I see your hand up.
So Dr. Hartung, like you, I've read the Minnesota report and a lot of the other reports that kind of, I guess, shine light on some of those things. I am not as personally familiar with some of the on the policy side, like what it sounds like you're suggesting that we make a recommendation more of like uses of funds and things, because I hear what you're saying related to the impact on state Medicaids when the state has to carve out, the rebate. So are your recommendation, I'm just trying to think, and this may be more a question for staff as I'm mumbling, but do we have, is that essentially something we could ask for in our scope, that we do like a report, or that I know when we did our listening sessions last summer, and we had quite a few 340B stakeholder groups that provided feedback for us related to the Senate Bill 192 report that we did. We received some of that, but it sounds like, Dr. Hartung, you're suggesting essentially that we have a report. I'm just trying to figure out how much we can get and how we could facilitate that.
Yeah, my recommendation is not for us to do something with stuff we don't have. I mean, it would require like the state start collecting data from 340B entities about kind of the revenue what they're billing other payers for 340B drugs, blah, blah, blah. And so it's not a trivial thing. and I don't think it's something that I'm recommending that our board specifically get involved in. I mean, I think that this would be a something that they'd have to subcontract for someone other group and collect new data to do. And I'm not even sure about like getting a handle on what the 340B entities are using those revenues dollars for. Because that's another black box and a mystery too. Although, I mean, there's purported uses of different, to extend clinical services for different groups. But I think that a lot of that is a little bit unclear as well. So.
Mr. Murray, your hand was raised first.
Yeah, I would like to second the idea that we suggest a report on this. I know we've had 340B entities that were very concerned about their income or revenue from the program due to a number of things, whether it's UPLs or reduction in cost of medications affects them. So, and I also, I don't know if it would address it, but maybe it could, the proliferation of the 340B program and the applicability or the ability for the program to serve the people that it was most designed to serve. I don't know how we could wrap that all up in one report, but maybe we could start getting some information to see how that might, how the 340B program might be improved.
Thank you, Mr. Murray. And mine is a question for staff. So Ms. Coder, you have the floor.
Thank you, Chair Bailey. I just wanted to state for the record that yes, the 340B drug pricing program is very complex, but there are a number of different entities that are eligible for that program, and health centers, which represent 5% of the entire 340B program, are required to reinvest that revenue into patient care. Other 340B covered entities do not have the same mandate and represent 95% of the 340B program.
Thank you for sharing that with us. So I have a question for staff. For staff, I believe there was a law passed related to 340B clearinghouse in Oregon in 2024 or 2025, kind of related to flagging claims with the basis of cost determination and things. Is that maybe, I guess I don't expect staff to have the answer to that for this meeting unless you do have the answer, but could we receive as a board a little bit of a highlight of the most recent 340B legislation? I think it was really related to clearinghouse things, so that we could just better understand the type of data that the state receives and what they might be able to help provide to us. I know that was a long-winded question, but I did want to ask it.
Yeah, so I can respond to that, Chair Bailey. At this point, I'd have to go do some research and bring it back for the next meeting. And I think if I was going to dive into that, then I might as well dive into the Minnesota policy that allotted for the audit to take place and the report to be developed. And maybe that will help the board with a decision on how to move forward with creating the recommendation for an audit of the 340B programs in Oregon.
I think those two things together, Courtney, you hit the nail on the head. I do feel like that would help board members greatly.
Will do. And Dan Kennedy.
Mr. Kennedy.
Right, I'm trying to unmute. So I guess I haven't read the Minnesota report, but I'm curious, to what end is this audit taking place? Is this to recommend changes in the 340B, a federal program, or what's the end goal here? I don't quite understand.
Everybody, I see your hand up. Did you want to respond?
Well, I would want to mention for the record, as you may be alluding to, Mr. Kennedy, we don't have the ability to make changes related to a federal program, right? So I think to your second question, what was the means to the end? When I read it, it has been a couple months ago. But I think Courtney may be able to fill in on the policy side, but I think it was informing the legislature a little bit of what flow of funds is and essentially how the process worked is beyond just all the granular information that was in the report. High level, that was my understanding, but I'm sure Courtney or other individuals that were involved or have viewed it from a policy perspective can probably provide additional insights or today or at our next meeting.
Yep, I think it's just a better conversation for next month. I think Dan probably has the most up-to-date information on it, but at a high level, Mr. Kennedy, Minnesota did a study, showed a lot of hospitals got reimbursed significantly, and clinics that are actually designated as 340B didn't get as much reimbursement. So it's an interesting report, and if you'd like, I can actually email it to you once I find it, so you can kind of have an understanding of what the concept was. But I want to give Dr. Hartung an opportunity to add any clarification from your recent study from this recommendation.
Yeah, no, I think it's just the 340B program has grown so much in the last decade. You know, it's multi-billion dollars. I think there was another Congressional Budget Office report recently that showed that it went from like $6 billion to $44 billion in 10 years. And so, but we really don't know where those anything about kind of where those the revenue that's being generated by 340B clinics and where it's going and what drugs and things like that. And so there's all this concern about, you know, contract pharmacy. A lot of the growth has been like these increasing in contract pharmacies and things like that. And so I think it's just the first step into kind of, you know, shining some light on kind of this black hole of what's behind this large growth. And again, like there was limitations about this Minnesota audit, and there's a couple other states that are kind of trying to do something similar, and so I thought it would be something that is worthwhile.
Thank you, Dr. Hartung. Appreciate your clarification. I see John Roy, your hand's up. You want to take the...
Yeah, it's a general comment concerning 340B pharmacies and the opening of pharmacies in Oregon. There's always a contentious discussion about how many pharmacies there really are in Oregon. And I would suggest that growth in the 340B program in Oregon is due to a growth in pharmacies opening that are 340B contract pharmacies or 340B covered entity pharmacies. It's the independents are going out. The serving in rural areas is going out. It's being replaced with 340B pharmacies, which have that additional revenue from the program. To me, when I look at it from a high level, why are the pharmacies going out that depend on the mechanism and the reimbursement from plans and PBMs and patient copays, and the ones that are opening are all relying on manufacturer rebates, manufacturer covered to the covered entity to keep that pharmacy open? I have nothing against 340B pharmacies. They serve a very valuable service, but it just is indicative of what's happening in the environment of pharmacy in Oregon specifically.
So I think Ms. Hoagland, you may have had your hand next. So you have the floor.
Yeah, I am not familiar with the pharmacy business in general. I do work at a health center that has a 340B pharmacy, and my concern is potential unintended consequences of shining a light. At the moment, the poorest residents in our state are being, you know, impacted by HR1 significantly, and many of them benefit from these 340B programs, and I would not want to you know, place those at risk as, you know, in the process of looking at more details of what's going on in the pharmacy business world. So I guess what I would say is there's a lot that's going to happen in the next year or so just to cope with the lack of money to take care of patients who are uninsured or patients who will be impacted by the Medicaid and potentially the marketplace insurance changes. So I just want to mention that.
Thank you, Lori. Dan, can I see your hand again?
Yeah, so I would just echo what Michelle Coder alluded to earlier, in that there are numerous 340B programs. There's disproportionate share hospitals, there's FQHCs, there's hemophilia, there's Ryan White programs for HIV. And I think in my talks with insurers and PBMs, there has been a long history of looking at 340B as a big pot of money that they could reach into and grab. So I would just caution us to not take a big swipe at this and not be too generalized. So that would be my recommendation. The purpose of the 340B program was to expand access. Okay, it wasn't to provide benefits for PBMs or insurers. That's my soapbox. Thank you.
I do want to acknowledge before I make a statement that Ms. Coder did have her hand raised previously. Before I make a comment, Michelle, did you still want to say something?
No additional comment. Thank
Okay,
you.
thank you. So I guess the other lens that I just wanted to convey as we talk about this recommendation from Dr. Hartung is, you know, we're having kind of separate discussions, 340B, which, you know, also is related to best price and things. And then of course, earlier we were talking about commercial things that we're seeing in the commercial space. But when you know, something I do want to share though, is even public, you know, available data from Medicaid and CHIP Payment Access Commission shares that 61.6% of every dollar on the Medicaid side and the Medicaid drug rebate program is linked with best price, and 340B is rebate. And so I just, that has an impact related to affordability. So I don't disagree with the lens that many of my colleagues have shared today, but I do want to reference that when we're talking about looking at net prices and things, that on the Medicaid side, those are reported numbers that at least to me are meaningful when I look at affordability.
Thank you, Chair Bailey. I really appreciate the conversation. I just think in the to be mindful of time, I did want to give Dr. Burns the opportunity to discuss her added on policy recommendation that came in after the board meeting. So Dr. Burns, I'd like to give you the opportunity to provide clarification for your recommendation to disband the Oregon PDAB.
Sure. I think I can do it pretty quickly. We've been doing this for 3+ years. We've really come up with nothing that's actually been enacted. It's been a lot of work for all of us. I think from listening to public comments and the stakeholders that they don't necessarily think that the right people are on the board, in the sense that there should be more consumer, perhaps industry representation here. I'm not making a judgment call on that. That's just what we hear over and over again. Yeah, and I mean, clearly from the recommendations, we have like an overwhelming desire as a committee to expand the scope of this board and to really look at other areas that we haven't been focusing on. When you look at all the work that the staff does, it's all around drug pricing. We've looked at upper payment limits. When we get down into the recommendations, you don't really see any of that reflected. So my recommendation when I sat down to really think about them was that we're kind of just repeating the same cycles. We've already done all these drug reviews once and abandoned them, and we're starting again, that maybe this is just not working and we should go back to the drawing board and try again. That's it. And the second one, I wasn't actually my suggestion, so I would pull that.
Oh, no, that was just added on because it was the conversation from last month when you and John were both having a similar conversation. So the same language is added on to where John had a recommendation, just for clarification from last month's discussion. So
I understand, but I didn't put that forward, so.
I'd like to ask the board members if there's any recommendation that is within the deck to be removed. Otherwise, for next month's voting, I will consolidate the ones that all have similar suggestion or suggested language and develop voting language for that. And then we'll have to go through each of the recommendations for a vote for each one. But to kind of help narrow down anything, if there's anything that the board themselves didn't want, I apologize. I'm going to jump to this one real quick. So last month's discussion regarding the confidential letter that came in from a stakeholder, and we don't have a policy or process for that to receive confidential trade secret information. We will continue that policy discussion next month. We needed to follow up with some more guidance and get the right people to have their input before I could bring that back into this conversation. But at last month's board meeting, it was discussed to possibly make a recommendation to exempt PDAB from the public meeting law that allows media present at executive session. Again, we can just put this forth for a vote for next month, but I wanted to just clarify that this was an added on recommendation due to the conversation from last month's board meeting. But Chair Bailey, I see your hand up, and then I saw Chris's, or do you want Chris to go?
I'll make just a brief comment. I would, if you don't mind, Courtney, I do want to make sure we just look at each member's board recommendations just in case they have things they want to remove. I know we jumped to this because we wanted to make sure this was added. I'll add more. I'll make a comment after Mr. Lehman makes his, but if we could just quickly go back and look at the other board members' recommendations so we don't pass those over. I know that wasn't the intention, but I'm a visual learner, so it'll just help me see them real quickly. And then I'll make my next comment. But Mr. Lehman, you have the floor.
Thanks, Chair Bailey. Courtney, if you don't mind, and Chair Bailey, if you don't mind, I mean, we had pretty significant conversations about a couple of the previous recommendations, and then I felt like Dr. Burns made a very significant recommendation, and we just kind of skipped on to the next without really talking about that. I feel like we should at least ask other board members if they have comments or, you know, feedback on the recommendation that Dr. Burns made about disbanding the PDAB.
Yeah, for sure, Chris. I apologize for jumping over that. If you have any comments regarding Dr. Burns' recommendation, happy to hear them now.
And I'm happy to start if that's okay, Chair Bailey. I know I see the other hands are going up, but I mean, I don't disagree with what Dr. Burns is saying. I mean, I feel similar futility in the conversations that have gone on over the last couple of years, and I think in open conversation that we've had in these meetings, none of us really support the implementation of UPLs. So the track that we're on is not something that the group is really behind or supports. And I know that this isn't the whole group's opinion, but I agree with Dr. Burns as well that we don't have the right people on this committee to give the feedback on all of the recommendations that are going to come from this about how we can improve the affordability or access to medications in the state. I think we need, just as Dr. Burns, and we've heard from public comments, more people from communities, more other industry folks, not as much pharmacy presence on the group going forward to really make holistic recommendations. So I'm not saying I would vote for it necessarily, but I'm leaning towards supporting restructuring this and creating a new mission for us. So
Thank you, Mr. Lehman. I believe Mr. Murray, your hand was raised next. So Mr. Murray, you have the floor.
Thank you, Chair Bailey. Yeah, I probably feel the opposite, and my recommendation of expanding the scope of the PDAB was probably reflects that. I also am frustrated a little bit by our past actions and our step back, our delay, although I support it. I would like to see this board, and I think we have the ability to and the knowledge to bring information forward. This board has been open to application for 3 years. People can apply to be on this board for the last 3 years. Where are the applications of people that might feel differently? So the people that want to be involved are involved. And why disband something where there is a lot of expertise, where there are, at least we can ask the questions. If we can't make decisions here, we make simply recommendations. Why don't we expand the scope of this, pivot a little bit into something that's productive and could bring clarity, or at least information, if nothing else, objective information to our legislators.
Thank you, Mr. Murray. Before I make a comment, Ms. Hoagland, you have the floor.
Yes, I totally support expanding, but not disbanding. My concern with disband would be that it would create a void where information and focus and concern are really important. And I think if we expand the scope of what we're doing, we will also draw in other people who would like to be on the board. So that would be my 2 cents.
Thank you, Lori.
Sorry, I did intend on making a comment and I was muted. So I did want to share, so I think in hearing feedback, I do want to go back to the people that are eligible to join PDAB, just to lean into what Mr. Murray is saying. Right now, our, I think it's 844 references that individuals who are healthcare providers or people with supply chain healthcare economics experience are able to be eligible. Individuals that receive money from manufacturers and things are not eligible. So just as a reminder, I wanted to level set on who is currently eligible to participate on Oregon PDAB. But I do want to reference that I do believe this board has actually made very many tangible outcomes since we started. I'm one of the board members who's been fortunate enough to have participated since the beginning. Just as a reminder, and staff, you can correct me because my memory is maybe not 100% spot on, but some of the things that I recall that we've had as tangible outcomes of recommendations from the board is to lower the insulin copay to $35 and delink it from inflation. So we did that in 2024. I would say that that was a very meaningful thing that we did. We also, through Senate Bill 192, we expanded PBM reporting requirements for transparency, or I guess that was a little more part of DPT, but we also did go through the hard work and process of the UPL report that we provided to the legislature. And I do want to lean in to share that I was a part of every single one of those meetings with stakeholders. And that was a massive endeavor that we did to really show to the legislature what a world with UPL could look like, right? So I'm not suggesting that I support UPL. I do not, but it was a lot of work to provide the report with that document for them to make informed decisions. So I actually believe that we did some other work on making recommendations related to biologic and biosimilar substitution. But I believe, again, staff can correct me on things that I may be in error of, but I actually believe that we have done hard work. I hear the frustration may be related to the drug affordability reviews and the data that we have and things, but I believe that as a board, we have worked very hard and there has been tangible outcomes that we have created together as a board.
Thank you, Chair Bailey, for clarifying that those have been the recommendation, a few of those recommendations that have been implemented, and hope to see an impact on the insulin in this year's data as it comes forward for the review. And, the original data set that was developed for the initial review, if you remember, there was quite a few challenges. And so we got below the 9 recommendations due to the suggestions at the time, because it was still a concept that was being developed, being a very new board. But this go around, our data is much more solid, much more, identifiable, transparent, and again, staff works a lot with trying to ensure that the data quality is going to help the board make the best decisions, right, to meet the statutory requirement. So, and as somebody that has set up multiple programs, it does take at least 2 years just to solidify a program for a meaningful outcome. We're only the third year in and we're still working with new data or the data concept. I think that in a few months, we're really going to see how the updates to the data concepts will start making it easier for the reviews of the drugs, breaking down from the preliminary list to the subset list, and the reviews will become a lot quicker. But again, only meeting once a month for 4 hours, and staff works for board members. Unless the board members want to start working with staff on a weekly basis so that we have the ability to have all these decisions done prior to the board meetings, and then can have more fruitful discussions at the, not that these aren't fruitful discussions, but there's a lot of guidance that the staff really leans into for board members at the board meetings. So, these are all things that it still takes time to rush into these things, I like to say. And I think for only being around for 3 years, we've actually shown a lot in our progress as a board to look at things without the expectation to impact a system under an upper payment limit concept that hasn't been shown to be a proven methodology, and Colorado will be the first to determine that. So, I think that overall the board has provided staff with wonderful recommendations to get to where we are today. And in a few months, we will have the selection of how you will want to present the recommendations for the drugs under review. But for now, with these recommendations that we're having a discussion on, if they are meaningful enough for board members to apply to the annual report, I can, like I said earlier, go back and start consolidating the similarities in the recommendations and then come back with a vote dynamic. But as Chair Bailey had mentioned, I just want to spend a few minutes because I do want to be mindful of time. We do have other concepts that we need to get through with the rubric. And at this time, I'm not going to ask if any will be removed or as a strong statement. This is a high level review. I'll bring all these back with their own voting methodology, and then the board will vote yes, no, if they want it into the annual report. So starting again with John Murray's recommendations. It was to eliminate the spread pricing in the Medicaid managed care programs. Number 2 was based on reimbursement drug cost figures on objective verifiable data sources, not through PBMs. Work toward the ability to use the NADAC cost bases in Oregon. Delink the PBM fees from the price of the drug or other fee rebates. And last on this list is to follow the allow any pharmacy willing to provide and participate, which would require plans to contract with any pharmacy that wants to join their network. The other list.
And Courtney, in consideration of time, I don't know if you have to feel that you have to read all of them. If we just want to maybe show them on the screen for a couple moments, and if board members want to say anything, or if, afterwards you could still provide kind of the consolidated summary for the next meeting.
Yeah, that sounds good. So majority of John's recommendations on this slide was either in agreement with other board members' recommendation or linked to a prior recommendation from the previous year. That's what each of the stars represent.
But for the record, Courtney, just because you showed prior recommendations from previous years, that doesn't mean those are current recommendations from the board, right? You just outlined for everyone to read what we had recommended in the past.
Yes, correct. So since you can read all of these, and they've all been posted online as well. So please make sure you're familiar with the material in the packet. If you have any other questions for staff, please reach out and let us know. And Dr. Hartung provided the recommendation again for a single statewide PBM or a preferred drug list. I'll probably break those out into 2 different votes. And then the 340B audit suggestion, which I'll provide more information on at the next board meeting. Chair Bailey, you had made a handful of recommendations as well. Last month, though, you did recommend for number 2 to be removed. And then we did add into a few of Chair Bailey's recommendations, any links to other state policies that we could find.
Courtney, since you're on the slide of recommendations that I made, I did want to mention another tangible thing that the board has done is the generic drug report. I want to give recognition to staff on the work on the generic drug report, especially the last one we filed had very rich and detailed information in it for those who choose to review it. That was another, if you're on the employer side reading about trying to learn about the supply chain or any other purchasers of healthcare, I want to thank staff and other board members for what they added to the generic drug report. That was another tangible work product that we've provided every year. I know things will change in the future related to that, but that was those were very meaningful documents.
Thank you, Chair. Appreciate that recognition.
They're great sources of information if people choose to review.
Thank you. Again, another slide from Chair Bailey. In regards to number 8, so the previous suggested UPL report, so there was a whole bunch of suggestions. I think there were 7 that were kind of identified as additional tools to use instead of upper payment limits, looking at other concepts. And so we just added the link for the report here. And then those recommendations are on page 26, 28. To be more familiar with that, it wasn't to suggest upper payment limits, but to go back and review what the other suggestions were, if there's anything in there. Is that my understanding of that concept, Chair Bailey?
Yes, but thank you for clarifying.
Dan Kennedy, very similar to other board member suggestions for having a single PBM. The policy suggestion to exempt PDAB from having media present. And then Dr. Burns's suggestion to just disband the Oregon PDAB. And then the added one from last month's board meeting.
But Courtney, I think for the record, I just wanted to recognize that I do think that bullet 2 under Dr. Burns, she did not want identified as a recommendation from her.
Yes. No,
okay.
Yeah, sorry, that wasn't my recommendation. And I do want to say, Courtney, the staff has been fantastic. My recommendation to disband the PDAB, I do not want it to reflect the work that you guys do. I understand if you feel that it does, but that wasn't a consideration that I took. You guys are doing top-notch work. I just don't know that we're acting on it.
I want to say the same thing, Courtney. Like, nothing that I said, I didn't intend it to reflect the work that you've done or that any of the other staff have done. I mean, the data processing and what you've created in terms of the visualizations has been amazing. It was more of a reflection on us as a board and what we've been able to accomplish, nothing from the staff.
No, I do understand where the board members are coming from. And I don't take offense to the recommendation. I do understand, but I do appreciate the acknowledgement that staff does work very hard for the board members to have these meetings.
Yes.
So with that, thank you for the conversation. We'll come back next month with the voting criteria to make those votes to add into the legislative report. But before I turn over to Chair Bailey, I want to give Dr. Hartung a moment.
Just listening to everyone's conversation, and I appreciate people are frustrated because there's the sentiment that maybe we're not doing as much as we should or can do, and I don't know. I'd like to amend or add to my recommendations. And I think we should, and I don't know, you know, if people disagree with me, that'll be voted down, but I think we should advocate that we are authorized to set upper payment limit in the state. And people can, you know, disagree with me, but I you know, the federal government is moving forward with their Medicare drug reimbursement, which is in fact setting upper payment limit for drugs for the Medicare program. And, you know, there's dialogue in the Trump administration about adopting favored nation prices for different drug distribution systems. And I don't know where that's going to go, but I'm just, you know, I think that we can, you know, think boldly about recommending policies here and be granted authority to do those things. And I think, you know, when the Medicare program, drug negotiation program was in development, that I think the thought was that, you know, it would apply to commercial payers and things like that. And that was written out of the language. So I think that, you know, we can, in some sense, at the very least, use any sort of granted authority to extend that drug negotiation process to on the commercial side. And, you know, I know there's big concerns about on the pharmacy and the patient access and things like that. But I think that those are all challenges that can be addressed and thought about carefully as we move forward. But I would like to see, at least from my recommendations, to continue to advocate for us to be granted authority to set upper payment limit in the state, at least to consider it for the vote in the next month.
Any other response to Dr. Hartung's comment?
Yeah, I like that idea. I mean, the way we pivoted and kind of just abandoned that was, I get it's not popular. And when I brought up like the Medicare fair pricing last month, that also didn't go over very well. So, but you know, we aren't making a lot of recommendations. The insulin thing was was great, but we piggybacked off of what the feds were doing. The PBM transparency was in the work already. Like we're not actually, I mean, it's good to like put our voices with things that we are recommending that are also happening, but this was one thing that we were kind of tasked to really look at and try and implement. And maybe it won't be successful and maybe we will not do it, but I would say if we, yeah, Dan, I agree. Like, why not look at it? Why not try?
Thank you, Dr. Burns. I will, based off of the comments that were just made, add that into the vote for next month. All right, hearing no other conversation from board members on policy recommendations, Chair Bailey, I hand it back to you.
All right, thank you, Courtney. So we are now moving on to the portion of our agenda related to the continued discussion and review of methodology for drug reviews and the scoring rubric and worksheet. So we will continue the discussion from last month related, and I think the month before, even related to the methodology documents for drug review and the scoring rubric and worksheet. Again, this is just a tool that has been provided to help individual board members be able to, I think, kind of help support the lens of looking at information. Again, it's not a tool that anyone is required to use, but Courtney, a senior policy analyst, if you could help continue to facilitate the conversation related to the rubric, it would be greatly appreciated by all of us.
Thank you, Chair Bailey. Let me throw it up on my screen here. All right, I hope everyone can see my screen. So as we've had a discussion over the last couple of months regarding a concept to look at drugs under review following certain scoring criteria that was developed utilizing the data presented through both APAC and the data call. I feel the board members have had a lot of time to sit with this and provide staff with recommendation. We had a really great suggestions to separate certain domains and provide a little more clarification. I would like to give the board an opportunity to highlight anything in the current rubric before I start into the next section, which is the process of using this and a scoring sheet that we would like to possibly use.
Courtney, I do want to just thank you and staff's efforts and trying to make this reflective of the additional feedback that you received in last month's meeting. I know that's a lot of work, so thank you for making the changes.
Yeah. And again, if the board doesn't have any substantial feedback for staff, I'm happy to discuss other options for how to do the scoring metric.
Can you lean in further to the term other options? But I see that Michelle has her hand raised. So Michelle, you have the floor.
Thank you, Chair Bailey. I had the opportunity to watch the video from the last meeting, and I think there may have been a question, and forgive me if this has already been resolved, on the utilization criteria.
Yeah, thanks, Michelle. So the utilization criteria, it was a discussion kind of about what the ranges of claims were. And Dr. Hartung, you may have a lot more professional insight on maybe the scoring. The scoring was originally set up to have, 2,500 or 25,000 or more patients on the drug if it was reported in APAC, and then it matched with other criteria like, is it better to look at utilization with a larger number with a low score or a different score? And just for clarification, all the numbers here are based off of our current ranges within the data caller APAC. So really everything was kind of structured out and showing that utilization with less than 3,000 seemed to maybe had a more impact on some of the other domains within the review process. So the ranges were developed based off of information, but if there's a different way that the board wants to look at utilization within those numbers, I'm happy to continue that discussion. And I know, Dr. Hartung, I just kind of called on you if you had any insight on that.
I was absent at the last meeting, but I did watch the video discussion, and yeah, I think reversing the quantities there from low impact to severe impact in terms of the number of patients taking the drug makes sense. I hope I didn't recommend this because this is counterintuitive as I understand it. I mean, the thought is that we're trying to flag those drugs that are being used by a lot of patients in the state. So and the comments on the video seem to question why it was set up like this, where that's the most severely impacted drugs would be used by the fewest patients, which doesn't make a whole lot of sense.
Well, and Dr. Hartung, that to me, that would also seem in alignment with how when we went backwards or we go back a few meetings when we decided for this year what we were going to focus on. And you are correct. I believe that we focused on number of patients was one of the pieces of our formula, right? Or not, formula would be the incorrect term, but number of patients. So if I'm hearing you accurately, Dr. Hartung, are you suggesting that you would swap the language in score 3 under utilization with the language in score 0, and you would ask for those to be flipped? Is that in alignment with what you were thinking? Or,
Yeah. So like score 3 would be 25,000 patients or more. And then score 2 would be 10 to 24,999. Score 1 would be 3 to 9,999. And then
Okay.
score 0 would be less than 3,000.
and this will be a question for staff that you may not have off the top of your head, but when we went and did our original data set, I recall that number of patients was one of our founding things we were focused on, but did we have a number that we used? And if we did, I guess I am not the person to do statistics. Anyways, I was just thinking, should we use that number, or I guess it would be too low because we were just looking at number of volume of lives impacted.
And you're exactly right. It was the number of lives.
Okay, it's just, yeah.
So, but yeah, I'm happy to make that change. And just flip the narrative around. Apologies for maybe understanding that differently during the discussions that we've had, but that's an easy fix. Was there any other domains that the board had any scoring or any feedback regarding the scoring and the narrative within the scoring dynamic? And again, there's been no large changes over the last few months, except for the expansion of adding the patent expiration and the MFP. But I see Dr. Hartong's hand up, and then Michelle, so we'll start with Dr. Hartong.
Yeah. So a couple things. On the access one, like some of these have like multiple criteria embedded in the same thing, and which I don't know what that means in terms of like if a drug has, if plans have it rated as non-preferred, but it scores high in terms of proportion of plans that PA it or whatever. But I guess I'm wondering if we just want to kind of simplify it and make it just like the proportion of plans that have PA or step therapy, or if it's possible, like PA step therapy or don't cover it, or some sort of just simplified metric, so it's not kind of mixing a couple different things if possible.
And that's fine, we can change that. Is there any one of those metric concepts that might fit better into the equity impact? Because the equity impact is this kind of you're gonna have a discussion because we don't have any data regarding race and ethnicity, age, or anything like that to really have a value of it. Would something like prior authorizations show more of an equity, or is that just kind of, again, plan design? Just throwing ideas out there for the board members to consider. But I see Michelle's hand, and go ahead, Michelle, and then I'll let the board members think about that before getting an answer back.
I'll just point real quick. Access, I would say this access plan design is separate than equity impact.
Okay.
And it should be kept separate, in my opinion.
All right, that's easy now. Go ahead, Michelle, I see your hand up.
I agree. I was thinking more along the lines of whether or not access is just restricted versus not restricted. And I don't know if we can set up a score 0 to 3 based on that, but I think that's what that is getting to. There are different ways to restrict access, and we could score based on that. And I think that the equity impact is really, in my opinion, looking at populations who would be disproportionately impacted by the specific drugs that we are reviewing and the treatments that those drugs, or the conditions that those drugs treat.
I'll have to look into, I'm not sure if we have the data point Michelle, for this round, but going forward in our future reviews, we will have more of that, you know, the demographic versus the race and ethnicity component to per the drug. But in this review, we don't quite have that information. But Chair Bailey, I see your hand if you want to.
Well, I'd like to give the floor to Ms. Hoagland, and then I'll make a comment related to access.
Go ahead, Lori.
So a couple things. Yeah, I think we definitely, the equity category is very subjective, and I hope we can come up with a little more information to determine how equity is impacted. And then secondly, on the specified stakeholder input, I feel like we need to somehow get a little bit more of that to justify categorizing different medicines. You know, it seems a little bit uneven. I don't know exactly how we can do that, but to get more stakeholder input on the specific drugs. I know we ask for it and we give voice to it during the meetings, but it seems like there's still not very much to base those decisions on.
And would you have any recommendations, Lori, on maybe some concepts that you can provide?
I probably need to submit those to you, Courtney, if possible. I need to take some time to think about it.
Okay, that'd be helpful. Again, having the conversation over the last couple of months, and having those suggestions are always helpful before the board meetings, but your insight would be really meaningful. Chair Bailey, did you want to go, or you want to offer the time to?
Offer the time to Mr. Lehman, and then I'll make a comment related to access after that.
Okay, go ahead, Chris.
Thanks, Courtney. Thanks, Chair Bailey. Could you go back up to the equity? Michelle, I hadn't thought of it. I think the way you're proposing it is that instead of having actual demographic data about the people filling prescriptions, are you talking about disparities or rates of the disease specifically that the medications are treating? Because we probably could get that pretty easily. And if we had a disease state that was really a lot more prevalent in certain populations, that could become an equity issue, right? If it's a price issue and it's an underserved population that is more affected by that disease state. I don't know, could you expand on that a little bit? Because it feels like that is somewhere we could go with that equity score.
Yeah, that's exactly what I was thinking. And there is information in the discussion on insulins about the prevalence of diabetes in certain populations, right? And so that's where my mind was going when I was thinking of this equity criteria.
Let me pull up. I have insulin, but I think that one of the other drug packets is a little bit. I just want to see if we do have, if staff has. Well, you're talking about. So Dr. Hartung, as I look for this, I'll go to you, and then Chair Bailey, you still can make your comment when you're ready. But Dr. Hartung.
I think I don't know how we handle it with this specific rubric thing, but the equity issue I think is it could be both. You know, it could be actual data driven or data identified disparities in the use of the medication in Oregon's population, because the data exists in the in APAC, and you know, I think that the goal is to start looking at that stuff for the next iteration. But then as you both noted, that there are, you know, different disease states have different prevalence, demographically prevalence variation. You know, what comes to mind is the gene therapies for sickle cell obviously have, you know, huge demographic influences, and are also very, very expensive. So those would be like, those would be things that, there are disparity issues that we would want to have to grapple with, just in the disease state itself. But I think it could be both in terms of disparities in who's receiving the medicines, as well as the disease prevalence and incidence.
All right, Chair Bailey, did you want to make a
Thank you.
comment?
Yeah, the only thing I was going to say related to access is in these reports for each drug, you do identify like what % for each of the drugs require prior authorizations and things. And I did just want to remind everyone, there was a 2024 report by the GAO on the impact of prior authorizations and specifically related to access. And so so the nerd in me is just sharing information about the GAO report with my peers, but also just saying on access. And, I think it's already built this way, I guess, with the scoring, but just pulling the prior authorization numbers from each of the drugs that we can, I mean, some of these drugs had 74% prior authorization required or something. But I do think we, on the data side related to access, those are solid metrics to use: prior auths, appeal denials.
Yeah, and that's where we utilize that information from. And I'm actually gonna have Heather, sorry to call on you last minute, Heather, but I want to continue the conversation around equity impact and getting the data, if we actually have anything from the 2023 data that can help support what Michelle and Chris were just mentioning.
APAC does have some information on race, ethnicity, and we were having issues pulling that all together in the aggregations. I can take another look for the 2023 data, but we did have some issues with bringing that in.
Yeah, so again, the intention is to improve that for the next round of drugs that for the 2024 drugs that we'll be reviewing. But for this process, it wasn't fully captured in the data. And so I'm hoping the board can maybe, from the material packet information, if there's anything you can provide for staff. I'm going to throw this over here. Hopefully you can see this. As Chair Bailey was just saying, this is the section for access that we're kind of utilizing. Unfortunately, anything regarding equity is just the narrative that was written for the health and equity section, unless there's anything else that's provided in these material packets that the board and staff can lean into to identify equity impacts, or if this might be just a domain that we'll have to address or adjust within the report, not fully being able to capture at this time. Chair Bailey's your hand up.
I mean, I just want to reference, just kind of reinforcing there's limitations with what we had from the data call in 2023 to help us better populate line item 3 on there. But the second point I wanted to make was, even though we may not be able to pull that information from the data calls, to me, still keeping it, in the rubric is something that I think is really valuable, even if the board members are just using that as they think through things when we get to a vote. So again, knowing that this rubric was intended to help us, but not as the only way a board member would each make their own personal decision. So I still find this highly, highly valuable to have the line item and what you had there, even if we're not able to pull information from the data call.
All right. Thank you, Chair Bailey. And just to show utilization, so in each of the packets, this is kind of the number that we're going off of. So Sorry. Trying to see what else. Was there any other example? I know that staff also provided the examples within the, it's not in this one. In last month's board meeting, we just haven't had them updated yet with what the examples are going to be from the rubric. We will be posting all the material packets of the drug review to be updated, hopefully in the next couple of weeks. And each packet will include the outline of the rubric concept that was agreed upon last month. I'm just trying to see if I can find it in my other document here. No. So again, I looked for this document, any other suggestions or concepts from board members on the rubric? Otherwise, I do want to talk to you about how the board would like to utilize the rubric when you start having the discussions next month. And again, showing, I don't know why that's blurry.
And Courtney, while you're looking for that, I will jump in and say that I recognize that Dr. Hartung has his hand raised. So it looks like you did find that, but Dr. Hartung, you have the floor.
Thank you, Chair.
Yeah, a couple more items about the rubric. On the price concessions domain, it's focused on the proportion of claims that actually receive concessions or some sort of rebate or discount. And on what the term different things at different places, but I think it should be refocused to be like what the average rebate is or average discount overall, rather than like the number of claims that actually received a rebate. So like, you know, is the average discount over 50% or whatever, or is it low? Is it less than 10%? So I think that's probably a more important data point.
Yeah, so we had this conversation last time. So that number is based off of the percent of discount, which is right here in the packet.
Yeah.
And so that's so that had been updated from a couple months ago when we had the conversation. So it's still not meeting the intention that
it just says 20, like in the middle, it says 50 to 75% of discounted, but the next one says 25 to 50% claims discounted. Then the next one says less than 25% of claims receive concessions. So it's both inconsistent across the domains and then a little bit ambiguous about what it's specifying. So I just want to make sure it's consistent and also specific about what it means.
Okay. All right. We will go through and make sure the language adds up to that, which is in the material packet.
Okay. And then the other kind of, I guess, majorish comment I had was about domains, therapeutic, the ones that after enrollee burden that talks about out-of-pocket costs. There's therapeutic alternatives, stakeholder input, patent expirations, maximum fair price. I'm not sure how I feel about just trying to like fit these into this domain structure, because I don't think they fit cleanly into trying to kind of quantify them in terms of their impact. I feel like they're more qualitative in nature. And I guess I'm wondering would it be better just to have a section that's like kind of other considerations, you know, not necessarily therapeutic alternatives, but like what are the therapeutic options for diseases in this category? A summary or synthesis of the stakeholder input rather than trying to like broadly quantify them into different groups. And then patent expirations is more of like, you know, just a sense for like what is the what's the time horizon until low cost biosimilars or generics enter the market? Like what does that look like? Because I feel like that's important for us to consider. I don't know if it's easily put into one of these buckets, but just like as a piece of information. And then same thing for a maximum fair price. Like has Medicare, will they be negotiating on this drug and have they developed a maximum fair price for it? And what is it relative to its list price? Again, as just like another piece of information. So I'll just leave that there for conversation.
Any board members have suggestions or feedback to what Dr. Hartung just said? And also, just as a reminder that the patent expiration and maximum fair price was were added columns from a couple of months back saying that it would be a meaningful point. I did work to put the language in just from my understanding of the market. So again, board members from your space of expertise, if there is additional language or alternative language to utilize to for the rubric, please work with staff. Because if I'm not receiving that information prior to the board meetings or prior to before getting this to a point of utilizing it as a tool, it may not be as clear to you to use that as one of the metric points. And so following what Dr. Hartung was just kind of saying, is the patent expiration, is the language and scoring dynamics within those two meaningful, or does the board members want to take an opportunity to submit something to staff within a week or so we can get this kind of shored up for next month? John Murray, I see your hand up. Go ahead.
Yeah, I'm supportive of the patent expirations category, and also I understand what you've put in here and support it. This is important to me. I want to know if there's market manipulation going on because it directly affects affordability to the patients. So I support it.
Thank you, John. Chair Bailey, I see your hand up as well.
Accurately, the intention is to use what's already public. So I want to make sure to reference, we're not looking at apples to apples, because the MFP prices that have come out for 2026, we would be looking at the MFP price versus the 2023 price and looking at the delta in pricing. Is that in alignment with what the intention was of this field?
And you're referring to the maximum fair price field?
So the 10, 20, 20, I mean, I just want to make sure when we're talking percents, is that what we're talking about? The MFP for 2026 for those 10 drugs? If versus what the data is for 2023? Is that where our intention was as a board?
Honestly, Chair, we haven't had a discussion about those intentions.
I just wanted to call that out, right? That if I'm not, I understand why we referenced it, right? But I just want to share with, that we would be looking, because 2026 is the first year that there's MFP pricing for those 10 drugs. We would be looking at 2026 data versus 2023 data. And then the deltas will we be coming up with are over, there's a 3-year delta. So I just wanted to share that with everyone.
I guess so. We did indicate if the drug was on the MFP. And so I don't know if they're, like you said, looking at that delta difference between the years or where it's at and what the trying to think of a data point that would help solidify that, how to
I mean,
determine that
I
percent.
guess one way to look at it would be like, what is the percent off current WAC and the MFP for 2026 and use that. I mean, look at it from that type of lens, look at it at the percent of 2026 WAC that the MFP is for those drugs versus what the percent of it would have been for 2023, the discount. I don't know. The people on the board that do more data analytics may have a very different opinion than me, but that's my layperson way of looking at it. But Ms. Hoagland, I see that your hand is raised, so you have the floor.
I guess my question would be, is it necessary to have 4 sections for each of those issues with the FMP, a yes or no, with a, might be all that we need. It's either the drug is being considered for an MFP or not, rather than to have to put it into more specific category.
And I think that's a great suggestion. So I showed this document previously as we set up kind of how to look at it. And I apologize, this is not my most updated one. But basically, again, utilizing the domains and then the selection criteria, we could come down here and just say yes or no. The reason I'm showing this is that when we have the board meeting to have these discussions and kind of collect ideas, would it be meaningful for the board members to have an electronic version where you can go in and you can kind of put your scoring methodology in, and staff would be able to see it transparently during those discussions to kind of see what the scoring structure would be for that drug and to help facilitate what drugs are meaningful enough to continue to have a discussion about and which drugs don't quite meet the criteria and don't need to be reviewed as strongly as the other drugs. So I think I kind of come to a point within the rubric itself where, like Dr. Hartung was saying, there's some areas that we need yes or no, and we can develop the electronic kind of platform to be yes or no. And it seems like it would be like some of these bottom ones, and then the rest of them kind of follow that scoring metric. But I need to have the board help me develop what the process of utilizing this. So when we start having the discussions, it's not just, you're not just sitting and having further discussions about the rubric and the topic within the drug packet. This applying the scoring and understanding the overall score will help facilitate further discussion to be more meaningful. So before I elaborate anymore, I want to take the opportunity to acknowledge Lori.
So I guess my worry is with the more subjectivity, the risk of having great differences of opinion and spending a lot of time with discussion of why you gave this one person gave it 2 points versus 1 point. I think that's why yes and no is a little more concrete in some of these.
Yes, and I agree. That's kind of why having a scoring process that you can use we staff would send you a link. You would pull up this document. It'd be updated, of course, to meet all the domains, and then this score in itself across all board members will show if majority of the board members agree on a percent of the drugs being above compared to having to sit and justifying just yes or no with me sitting here going, does the board do each board members kind of thing. So the board has the opportunity to provide the insight from like a form, electronic form during the review process. And again, it's utilized it to, and the other option is the board, each board member does not have to use this option. You can have a discussion and let the other board members know. But at some point the board will have to determine how they want to look at the review packets. And this is just an option to have and facilitate meaningful discussions and around all the drugs, because in November and December, all the drugs will be under review. We're not breaking them out into material packets. The board will need to decide what drugs no longer need to be reviewed under this process and what ones have the most impact that fall under the statutory requirement to eventually get a vote to. And Dr. Hartung, I see your hand up, so I'll give you the opportunity.
Yeah. So I see a lot of these domains are definitely like can be easily broken down into kind of data-driven severity scores or impact scores as you have done. But some I feel like maybe just go back to that form again. Yeah, some are just kind of like alternate or other considerations. So for example, what if we go through the process and we find a drug to be severely impacted in terms of all the data-driven metrics that we go through, but and there's other considerations we learn because of staff has put together this other consideration section that generics are coming in the next year. And so I feel like that kind of short circuits the process. They're like, okay, this is an affordability concern now, but we have substitutable generics coming very soon that, are going to be true affordability solutions for patients and payers for or at least they should be and have historically have been. So I feel, you can make it the same thing with the argument about like therapeutic options or whatever. So for instance, the anticoagulants, Eliquis or whatever, it's very expensive. It's used by a lot of people. A therapeutic option is very cheap warfarin, but there's some debate about, whether they're not equivalent, obviously, but a lot of people still use warfarin to, it's still effective. And so there may be, but it's hard again to kind of parse that into the scoring framework. And what were some of the other, what was some of the other domains at the bottom again? Maximum fair price, just knowing like what Medicare is doing in terms of its negotiation. I think, obviously we can make an affordability determination in Oregon, but knowing what Medicare is doing, I think would provide a little bit of color to making recommendations about, Medicare has indeed found that this drug is not affordable as currently priced. And so we can kind of go along with that and use it to support a decision. Or a recommendation. So, I guess my recommendation maybe is, can these items just be taken out in terms of the rubric itself and just put into like things to consider as we go through? I know it adds subjectivity, but I think it's difficult to like again put these into different criteria and score them as such as it's been noted.
So Michelle, before I get to you, I just want to be mindful of time because we do need to look at taking a break in about 6 minutes or so. So Shelley can transition the meeting to.
And Courtney, I can actually stay till approximately 11:45 or 10:45, sorry. So I can stay about 30 more minutes.
Okay. So then we still plan to take a break. But before we do that, Michelle, I'd like to hear from you, and then I will try to provide some more context to what Dr. Hartung was saying.
Yeah, and I wanted to pose a question to the board, with what Dr. Hartung was saying specifically about patent expirations. If we know that a patent is going to expire next year, is that where we want to focus our energy? And maybe all of these domains don't have the same weight in scoring. if that makes sense.
Dr. Burns?
Yeah, so that's been an ongoing issue. We've had a lot of conversations about that over the years, and especially with that first year when the patent comes up, as you know, pricing can still be quite high because we have to use data that's 2 years old from, you know, the reporting that we get from plans and the all payer, all claims. We're kind of in a position where we're looking backwards, even though we can see in the future that things might be less expensive, which is why we still have conversations about things like Humira. So it's a challenging one. I think having that there so that we're all aware of that's really important because that definitely can change the landscape. So I just wanted to acknowledge that we have thought about that, Michelle. We've talked about it, and kind of our constraints with how this is set up makes it challenging.
And Dr. Hartung, I'll make a comment. I know your hand was raised, or are you, sounds like, looks.
So I don't think I put it down, sorry.
Oh, okay, no problem. I mean, the one comment I was going to go back to Courtney's like overarching question to us, at least personally, the way I always saw this rubric was, so I guess Courtney, to your point about real time, like getting you the information and things, I always looked at this from just the lens of a tool to help individual board members, but I was never myself intending on it being like, hey, we vote, and if the consensus is already don't look at it, like I would like the flexibility, especially like on those, the last 3 rows, that there is individual board member knowledge and personal decision making that would lead it to not just use the survey and then decide based on that, but that it's just a tool that each of us use. So when we disseminate our information to Courtney about whether or not, you know, we believe that drug may present an affordability challenge, that was just something we used individually as a tool. That's the lens that I was viewing this from.
And the board can absolutely utilize it independently. And Chair Bailey, again, you'll have to facilitate those conversations for each drug to get the conversation to with those drugs based off of how are
and part of me making that comment right now is just to solicit, are other board members viewing this rubric that way, or do you see it a different way? When we go to voting on the drug, like do board members see this tool being used differently than what I outlined? But Mr. Kennedy, your hand is raised, so you have the floor.
Yes, Chair Bailey, I see this in much the same way that you do. My thought was that this was going to be a tool for us to utilize and put everything in a nice, concise order for the discussion.
Okay, and Mr. Murray, I see your hand is raised.
Yeah, I support the use of the rubric for our own personal decision making. You know, different areas, different categories of the rubric have more importance to me than others, as I think about the patient walking up to the pharmacy counter, for example, and how those things might affect it, or what I've actually seen in my practice. So this provides a structure for my approach to the decision, so I appreciate it.
Thank you. So when we think about when we are looking at voting on drugs that may or may not present an affordability challenge, Courtney, you were referencing that we will essentially each have all the information available in all the packets that we've discussed in each of the meetings, and then we will just kind of go through them drug by drug, and board members will be able to share some of their insights and then vote on whether or not they personally believe each drug may or may not present an affordability challenge. Is that in alignment with how staff has been viewing the meetings that we're voting when we vote?
Staff doesn't have a concept or a process, because that's where we have to lean into the board. That's why we're having this discussion, so that staff can help set the intention up for how the board wants to vote or use this tool. So I really appreciate the clarification of the intention that the board members just want to use this as an individual tool. I will update the the PDF to meet all the current domains and kind of the structure and send that out. So if board members kind of want to see, just have it as an additional document to reference instead of just the Excel spreadsheet. And then when the board comes to each drug to review, you can utilize it to your intention and then have the vote at that point for however you want to do.
Okay, so
I believe the intention of the setup was to have all the voting done in January. So have meaningful conversations of all the drugs in November and December, and then spend January time voting for the drug.
okay, thank you for clarifying related to voting. And again, Courtney, to yourself and the team, I think this scoring rubric, although we all have personal things we want to add or delete, you creating this and then helping us, helping solicit our feedback on how to improve on it, is a huge step forward. A huge would not even be the correct word, but like from where we've been in previous years. So while we all may disagree slightly on different pieces of it, I just want to thank you for helping us make this available to us.
You're very welcome. All right, well, again, I don't have any other questions. I feel like I have the direction that we as staff need from board members, unless board members have any other instructions regarding how to set up the rubric for the upcoming reviews. Chair Bailey, if there's nothing else from any of the board members, can hand it back to you for a break.
All right, let's go ahead and take our 5-minute break. So it is now 10:22 a.m. So we will return here at 10:27. Thank you, everyone. Okay, welcome back, everyone. Melissa, if you could please call roll just so we're aware of which board members are here for a quorum, and then we will move forward with the next section of our agenda.
Chair Shelley Bailey.
Present.
Vice Chair Amy Burns.
Present.
Dan Hartung.
Present.
Lori Hoagland.
Present.
Dan Kennedy. We'll come back to Dan. Michelle Coder.
I'm present, Melissa. Thank you.
Oh, thank you, Dan. Michelle Coder.
Present.
Chris Slayman.
Present.
John Murray.
Present.
We have a quorum.
Thank you, Melissa. So the next portion of our agenda is related to the drug affordability reviews. The board is conducting drug reviews per ORS 646A.694 and OAR 925-200-0020. At the July 16th meeting, the board reviewed 6 drugs in Group 1. On August 20th, the board reviewed 5 drugs in Group 2. On September 17th, the board reviewed 5 drugs in Group 3. Today, we will review seven insulin products in Group 4 and the final review group. This will be a public comment period for each drug per ORS 646A.6943. No one has signed up to speak, but I will read the letters the board has received. The letters that the board have received related to insulin glargine are 4 letters, one from Carissa Kemp from Sanofi, from Cynthia Ransom with Eli Lilly. We received 2 letters from her related to that. Erin Callahan from the Diabetes Patient Advocacy Coalition. And we have no past speakers and no speakers signed up for today. In addition, I am leaving the meeting, so I will be turning it over to Vice Chair Dr. Burns to help facilitate the rest of the meeting, as well as to Courtney Whitlock to lead us through the affordability reviews. Thank you to everyone.
Right.
So Courtney, you have the floor.
Yeah, thank you, Chair Bailey. And thank you, Vice Chair Burns, for taking over and facilitating the rest of the meeting for us. I'm going to share screen and just provide another kind of high level from what what Chair Bailey was just saying of the roadmap for where we're at, and then the intention of today's insulin review on Glargine. So today we're on Group 4. With the intention of after today's board meeting, starting on Friday, we will not receiving any more RFI, so survey information from patients. We'll be closing that down so that we as staff can solidify all information into the material packets and get them to the point where the board has all the information that we have heard and discussed over the last handful of months. And then get those updated packets posted for board members to review to facilitate the discussions of each drug starting in November through December, with the vote happening in January. One of the things, just to remind the board, starting January 1st, we will fall under our new statutory requirement where the board can select up to 9 drugs, which is different from the current legislation requirement, which is to identify 9 drugs. So we'll have a little bit more flexibility for the board to identify drugs that truly show the most impact to the healthcare system and patient out-of-pocket costs. Again, at the end of this year, we are still determined to have the annual report done. Apologies, I just lost my screen. We will be facilitating the annual end-of-year report, which will include the price trends, the subset list of drugs currently under review, the policy recommendations, which we have been discussing and will be voting on next month, and then kind of a program update and progress report will be due at the end of this year, with all the drugs under review and decisions and concepts put into a report for in March of the drugs that will be voted on. So before moving on, do we have any questions from board members about what's happening over the next couple of months for the review process? Seeing none, just as a reminder, as Chair Bailey mentioned, Group 1 and Group 2 have been reviewed under those therapeutic classes. Last month was anti-diabetics, and this month is insulin products. So going forward, I just want to take a moment. I'm going to hand it over to my team. I was out for a couple of weeks over the month, and my team, Pay and Heather, put together the Glargine packet. And so, Dr. Burns, I'm going to hand it over to you to start the discussion. But Pay, if you can get your screen ready to share so the board can have any discussion from the topics. All right, thank you, Vice Chair Burns. If you have any questions, I'll be on the background.
Okay. Does the board have any questions about the review?
And I apologize, Pay, you're gonna need to share your screen with the insulin packet and help the board scroll through. Thank you for the visual. And then if you can let the board know kind of what the updates are, because the insulin Glargine packet is a little bit different than the other drug packets, due to that all the Glargine drugs were put under one packet for review. So Pay, go ahead and scroll down to the data.
Yeah, of course. So previous groups we had listed the drug and the therapeutic alternatives in the charts. But for this packet, we just listed all the insulin Glargine products together that we're reviewing. So this is a review summary page. Should be fairly similar to the past groups. Please let me know if you want me to slow down with the scrolling or just stop on any particular page.
Was there any section in particular that the committee wanted Pay to focus on? Yes, John.
Thank you, Vice Chair. In our previous conversation, we were talking about the differences in time between 2023 and now, and I guess I'm interested in hearing from those who have some information about this more than I do, about some of these drugs are in cost control programs now, it seems like to me, or there's significant savings between what we see in this data and maybe what is available in the marketplace now. It would affect affordability decisions, in my opinion. And when I advocated to have all the Glargine insulins reviewed at once, it was to see market anomalies between the different drugs, because it's the same drug, but different manufacturers, different brand names and things. And I still value that. But what has happened since this information has come out? If somebody could help me to understand that better, please.
John, to partially answer your question, it is true that a lot of these had some discounts, and you'll see that further down in some of these other tables. So yes, there are some that are taking effect in 2025, I believe, 2026. So with that, yes, some of these are impacted past the data that we used for this particular review.
And Michelle, I see your hand up.
Yes,
Go.
Michelle.
My understanding, and I could be wrong, but my understanding is that what has changed is the out-of-pocket expenditure for enrollees or patients, but not health system expenditure.
And to follow up real quick with that, Michelle, you're correct where with the law that was passed to cap insulin at 35, it definitely reduced the out-of-pocket cost, but is still showing cost to the healthcare system. And again, this being drugs from 2023, where that policy was not fully implemented yet into the collection of the data. I believe that started in 2024. So the next iteration of the drug review will show that variance and the difference. And then kind of following up with what you're saying, John, I know the challenge with part of what the PDAB does is the statutory requirements to look at the drugs from the year before. Unfortunately, how the data has to come in through various other programs and how it's set up, we're actually kind of like 18 months to 2 years behind in showing what's actually going on currently to what the data that we have is representing. And I just want to remind the board that I know that's one of the biggest challenges, but we still need to maintain the scope of reviewing drugs from the previous year or from the year of the data that's being presented, and kind of looking at what was happening in that time, and it's a retrospective review to just let legislators know. And then going forward, the intention would to be create benchmarks and then be able to show those trends going forward and hopefully to make more sound decisions and explanations and recommendations to the legislators. But for this packet of material, is there any sections that the board is most interested in maybe looking at the payer total expenditure section to see what's going on with that?
Yeah, Dan.
Yeah, just wanted to, maybe this is self-evident, but just flag that I was looking at the WAC changes over time on page 8, and there appears to be a pretty sizable reduction in WAC for Lantus, but not the other options. And I don't know if those, I mean, if that aligns with some of the changes in terms of these companies reducing the, creating a lower list price product or what.
Yeah, so actually, I looked that up, but it was because Lantus, their manufacturer, Sanofi, had committed to a lower price in their insulins, particularly for Lantus and Lantus SoloStar.
Okay. Yeah, so I guess that would be like, that's kind of an interesting data point in terms of just looking forward in terms of the 2024 list prices and 2023 spending. Lantus is, both Lantus are the top Glargine products if you combine them. So if, I don't know if we would see that, if the other companies have kind of matched that, those changes in list price, or are expected to.
Dan, as a thought, we have not heard if any other manufacturer plans to match what Lantus has dropped, but it will be interesting to see if there's any in the upcoming future due to the administration requests for manufacturers to look at dropping prices. But Dr. Lehman, I wanted to.
Yeah, Courtney, I didn't catch this earlier, but are these the right WAC prices for a 30-day supply? Because at my pharmacy, I'm not spending 57, I mean, not even close to $57,000 for a 30-day supply of an insulin vial. So I just question the numbers that are in here. And I'm sorry I didn't catch this before when we met earlier in the week. I didn't really notice it until Dan pointed it out.
I'll have to lean into pay.
Yeah, this is based off of the units that our clinician gave us. She gave us 600 units for a 30-day supply, and that was the number we based it off of.
John or anybody else, do those seem off to you guys?
Yeah. So pay, does that mean 600 units per day times 30? Or what?
No,
How is the math here?
600 units for the month.
And then, okay.
Yeah, that doesn't seem right.
No, it's not
Yeah,
right.
yeah, it's high, right?
Sorry.
No, it's okay. I will check on that and then circle back to this next month.
Thank you, Chris, for pointing that out. We will address that. However, we can't
Yeah,
get
sorry I didn't catch it earlier, or we didn't catch it earlier, Courtney.
No worries. Again, like I said, I was unavailable myself for a little bit there. So, but I do appreciate that we're catching it now, before the actual voting. This is why we set these up, so we can have these conversations and board members can help staff, identify any corrections or anything else. So I would correct that. Was there any other maybe sections or topics within the packet for here the board would like to go over or have clarified? Hey, maybe if you can scroll gently through and give us a little bit of time to see if there's any other idea or sections to look at. Go ahead and stop here for a second so you can review. So the percent change of WAC pay, or these percent changes, or would they be impacted from the numbers above?
These are based off the unit WAC, so it's not based off a 30-day supply.
Okay. Does the board have any feedback or comments for the change of WAC over the years for any of the Glargine drugs? And if that looks normal, we can continue to scroll through.
It looked consistent with the table above, which I took that to be population. I didn't realize that was an individual fill.
All right, Pay, go ahead and scroll through just a little bit more. So regarding the AAAC for the Medicaid FFS quarterly reports, I think these probably reflect a lot more closely what's actually going on versus the numbers above. So it might be a better guideline And then, like I said, we'll have those other numbers updated. And if the board doesn't have any other comments or concerns regarding this information, you can scroll pay if there's any other thing that you put into the packet that you feel is relevant for the board to review. Otherwise, there is this large data sheet here that shows the net cost based. This is off of the data call. So this is carrier information for the Glargine products. I know there's a lot of points to look at, but Michelle, I see your hand up.
Sorry, I did have a question about the AAAC. What is the unit of measure for that one?
Go back up to the AAAC first, please. What is the unit of measure?
I believe it's similar to the unit walk where it's how much they pay per unit.
Okay.
I'm gonna go back to the big table if there's no other questions.
Hey, if you can take a minute to go over the data topic. So just identifying the total number of enrollees, claims, and what
Yeah.
those totals indicate.
Yeah, like Courtney said, this is from our data call, so this is what the carrier submitted. And based on enrollees, the generic version had the most enrollees, but I think the board might be interested in the percent discount, which is this row here for each of the different insulin products. And then down here is the average payer spent per enrollee without price concession and with price concession. These two rows, the last two rows here.
And I think paid, Dan has his hand raised.
Oh,
Yeah.
Yeah, the discount, because is that reflective of the entire sample of claims, or is it just reflective of those claims that received a discount? Because it ranges from 50% or so with Basaglar, KwikPen to 96% with Toujeo, SoloStar. So is the discount of just those that got the discount, or is it kind of averaged across all the claims?
So the percentage of discount that you see here is basically a division from the amount of the price concession, which for Basaglar 138, 142, divided by the total cost, the 393,989. So it's based on a cost perspective.
Okay.
And I just wanted to go back to Michelle's question. I looked it up real quick regarding your AAAC question, and the rates are based on the actual cost per invoice. So I just wanted to clarify that. And then also it says that it's the rate based on the actual cost to the pharmacy for the drug dispensed plus a statistically validated dispensing fee. So it's cost plus fee for dispensing. And then to Dr. Hartung's question around the percentage, does that seem reasonable that the percent discount was set up like that? And the reason I ask is that that's the same process that we set up for all of the percent discounts. And if it's going to be a rubric metric, I really want to make sure that we're capturing the intent of how the board wants to review percent of discounts.
Well, I have a lot, I mean, I have a lot of concerns with this data set, the carrier data, because it's only commercial, it's just a subset of the commercial payers. So part of me doesn't know how much to extrapolate it to the entire universe of commercial players, let alone let alone to Medicare, and it's completely not extrapolatable to the Medicaid program. That being said, I'm sometimes cognitively tempted to apply the discount we estimate here to the entire APAC gross spend, because that's really what I'm interested in from a healthcare system perspective, is like what their net spending is, but we don't have net spending in APAC, just gross spending. And so yeah, I kind of sometimes just apply these implicitly to the commercial APAC figures just to get a sense. And so then these percentage discounts kind of line up with what I've seen in the literature about discounts for insulin. Like they're quite large now because of competition, especially in Glargine space where there's a lot of competition, different products and whatnot. So yeah, this generally lines up with what I thought we'd be running at in terms of a discount, rebates for these products.
Yeah, and again, we understand that the data call information is based off of only 11 carrier submissions, and that it doesn't capture the whole universe of what's happening in Oregon because it doesn't capture Medicaid or Medicare. But it does kind of create at least enough of an insight. And then if you can go to other material to review, it does often align. It may not be as accurate or as insightful as we would love it to be, but I think for what the intention of a review process for the costs and impact, it kind of can create that benchmark for the board to determine. But Vice Chair Burns, I see your hand up. I didn't want to make sure you get your response in.
Yeah, I agree with both of you. I think that this is good to have, but with an asterisk, right? Because we're getting a piece of the puzzle and it's self-reported, and it's not even an entirety of that particular piece of the puzzle, but it's still insightful. So I think that it should be included. But again, and I think that it outlines it when you read through it, that this is a portion and it's not everything. And that's, as long as we take that into consideration, I think it's pretty valuable.
Thank you, Vice Chair Burns. Is there any other feedback or comments on this? The net cost information. Otherwise, if not pay, you can probably scroll down and give a highlight to what the other tables are indicating.
Yeah, so this is another table detailing the gross spend per claim and also the net spend per claim, and it also breaks down the price concessions per claim down by market for each drug.
I see Dan, you have your hand up again.
I just had another question about the rebates, maybe for the board members about, one thing that struck me is that not only in this report, but other reports, like, that there's quite a bit of variation in like just it's what's called the percentage of claims with price concessions applied. And it always struck me as odd that, sometimes these are pretty high, but sometimes they're pretty low, like, which to me it suggests that some claims they're receiving no rebate whatsoever. And so I just wanted to ask my other board members about, is that correct? Are there certain drugs or certain claims to certain payers that aren't rebated at all?
Yes.
Okay.
And maybe I can provide a little more information based on this table. based on your questions, Dan, is that when you look at the spend per claim, gross, and in this case, gross being what was reported by the carriers as their costs prior to their rebates, discounts, and any other forms of remuneration they might have received, that would be that total divided by the total claims. So the 401 for the gross is the 393,983, which was the total payer spend, divided by the total number of claims of 983. So in these calculations, all claims are considered across the board for this table. I hope that is helpful.
Is there any other questions on this table? Okay, then we're gonna move on. So table 9 and table 10, I don't think I can show both at the same time, but they're the same metrics, but the green table is from APAC and this blue table here is from the data call. So it's the same information, just from 2 different sources. I'm going to show the APAC table first. Are there any questions on this one?
And I think just because Michelle's new to the board and just to kind of provide some content, Michelle, that the APAC information is based off of gross and it collects information across all systems, so commercial, Medicaid, and Medicare. And so they're always going to be quite a bit higher than anything we get from the data call, which only collects the net from 11 reporting carriers. So there's going to be quite a significant difference in the numbering and the costs and stuff like that, but it's to kind of provide the overarching to a little bit more narrow what's going on in the market in Oregon anyway. And we're happy to answer any other questions that you may have, because I know you're kind of new to the reviews, and so don't hesitate to reach out if there's anything that you're seeing that staff can help clarify for you. But with that, Peg, if board members are ready, they can see the data call information. And if there's no conversation from board members on this, I think we can probably move to the next sections, which is again that health costs to the health insurance plans. And hey, is there anything the board should know regarding this information or the tables that you're going to provide?
Not in particular. It's pretty similar to the previous groups that we've seen in the previous packets. These tables just broken out into each of the enrollees, utilization, expenditure, and the metrics. So I'm just going to show the claims and the expenditure tables.
And I also wanted to point out to the board real quick, as I was looking through the rubric information, and the information for the insulin doesn't line up as cleanly with the data or the information for the other drugs under review. When the rubric was developed, it was primarily focused on the drugs. And insulin is a little bit different. So again, as you start conceptualizing how to look at the drugs for cost impact to the system and patient out-of-pocket costs, just know that when you get to that point with the insulin, the rubric may not fall exactly into that, but since the requirement is for the board to select at least one insulin product, and it's all based off of the same therapeutic class, hopefully the conversation can occur without the assistance of the rubric, or within knowing that there's not the exact alignment with the data points in the rubric as there is to the insulin products. So when you're looking through the insulin, just be more mindful, maybe pay attention to what it is and how meaningful the utilization for the drug is versus the expenditure versus the where the most impacts for cost are, and not determine that the rubric will be your best assistant for that. So I'm happy to answer any other questions or clarify anything else, but I just wanted to point that out as this information starts coming forward, that we either have to develop a whole new rubric for insulin, which we can for the next iteration, or change the numbering in the rubric to allow for the variations of the data.
This is the cost per enrollee. This is for the system, not the out-of-pocket cost for patients.
Yeah, and then just as a reminder to board members, most of the tables that are highlighted in green are associated with the APAC data. The dark blue columns are mostly associated with the data call information. Light blue is just general information that we put in there. So when you look at any green table, you will be looking at that gross cost. And there's no topic or conversation point. Oh yeah, Michelle, I see your hand up.
Sorry, quick question for the board. Was curious if there had been an discussion around the potential to carve out Medicaid in calculating these median costs, because those costs are zero.
Well,
And
this is the cost right here is the cost to the system. So it would be like the cost to Medicaid, not patients.
oh, per enrollee. Okay, got it. Not out of pocket. Okay, thank you.
Yeah, no, we've talked about that a lot, Michelle.
If there's no further question on this, then I'm gonna, oh, Dan.
Well, we need to get more accurate WAC data, but just, I mean, it does appear that Toujeo is magnitudes of is a couple fold higher, more expensive than the other Lantus. So just in terms of like identifying, you know, if any of these products are maybe an affordability issue, that certainly seems, with high utilization, seems to be leading the pack here.
Yeah.
That's a great observation, and I hope that that continues into the discussion when you determine a drug, the insulin product anyway.
It also had the highest rebate too, though, so.
Yeah. Maybe it's in another table where it shows what that rebate difference is.
Yes, in one of the previous tables. We could go back at the end of the review if we'd like.
Okay. Thank you.
It was like 75% or something like that.
Yeah. Any more questions? Okay. And then this is the system, the cost per claim to the system.
All right. Hey, since we're not hearing anything from the board members, you can go ahead and go to that next section.
Yeah. And these are similar metrics based on based on the data call, except the market segments is individual market, large group, and small group. So this is the claim numbers. Oh, sorry. We have a little bit more on the next page here. And then these are the enrollees. And then the market's annual spending. Are there any questions on the annual spending from the data call? Okay, we're gonna move on. This is the payer paid for each of the markets. Okay. And then this is the enrollee out-of-pocket cost for each of the markets. Are there any questions about this one? Okay. And then this is quite a big table. I'm not sure I can show everything at the same time, but let me. I think I can barely get it to fit.
I think that's okay, Peg, 'cause actually now it's really small for us to see. And we have to blow it back up and just be mindful to kind of give the board some time to look at the bottom section. All right, there's no questions that I can see on this section. I think Peg can go ahead and scroll down to that last section just to have the board review those numbers. And if there's no comments or feedback in a moment or so, you can scroll down to the other sections.
Are there any questions or comments? Okay. So the Medicaid CCOs, Courtney, do you have
Yeah, so this is information provided from CCO reporting for the greatest increase for the years of 2022, 2023. And the reason why this was kept in there, I know that we removed most of their CCO information, but what this shows is the significance in the year-over-year change in spending. Even though it's 0.1, it's still showing some sort of impact to the healthcare system from the state level for the Glargine, but it did come from the OSU pharmacy report that we often lean into for the CCO information. And if there's no questions about that, Peg, I think you can probably scroll on to the next section that just shows the plan design for 2023 and kind of where each of those Glargine products fell with the requirements of prior authorization, the step therapy, if the drug was non-preferred or not covered. Again, kind of looking at this from an access to patients, if there's any one that represents more concern than any other one. Vice Chair Burns, I see your hand up.
This is kind of just a dumb comment. Just the section there with the Glargine for the Medicaid CCOs, because it's in dark blue, it's a little, it kind of codes like the carrier data in the sense that we've got green for the all payer, all claims, and dark blue for the carrier data. I don't know if you want to pick like a hot pink or something for
Switch it to
a
orange.
light blue, orange, fine.
Okay.
Just it's really nitpicky. When I read it, I totally understood what you were doing here, but I mean, since everything else is color coded, it's just a suggestion.
All right, thank you for that. Dr. Hartung, I see your hand up.
My question is on the step therapy PA table there. I'm not sure what format the data is coming to us in. But if it is it, you know, if we're trying to think about total access restrictions, you know, it'd be nice if there was some sort of like aggregated, like what proportion of plans had drug X, had a PA, step therapy, or didn't cover it, as a kind of a single metric of access restrictions. I'm not sure if that's possible, but it would be helpful.
So in this table, the way that this information was requested, at least for the first two, for the prior auth and for step therapy, was a yes/no field based on plan. And so this is a calculation of how many of those plans identified were noted as having or requiring prior authorization or requiring step therapy. The preferred, non-preferred on the formulary, it was a drop-down selection that they were able to use. And this is a percentage of for that drug, how many were noted as non-preferred and not covered. Also the same thing, it would be excluded from the formulary. I hope that that is helpful, but I'm not sure if there was something else that you were looking for that you're not seeing here. If so, I might need a little bit more clarification.
Yeah, so for instance, if we had 20 plans reporting on Lantus and they each reported yes, no prior authorization, yes, no step therapy, yes, no covered, not covered. It would be, I think it would be helpful to know, because are some of these mutually exclusive, I guess. So obviously if it's not covered, there's probably, they don't probably have a prior authorization or a step therapy. I'm guessing, I don't know. So, but like some sort of like combination of those three things where it's like for the 20 plans that report on Lantus, what proportion of them either didn't cover it, used prior authorization, or used step therapy as kind of, okay, then we have a more global measurement of access restrictions for Lantus. I can tell that, you know, it's fairly restricted, but I don't know if it's appropriate to add 60 to 22 to 1.3% to, you know, say, well, I don't know, like 80% of plans restricted Lantus or something like that.
I think what you're referring to then some type of combined metric that is taking those three things into consideration. For example, if you have a yes for prior auth step therapy, something like that.
Yeah,
I can put some brain power to that, see what maybe we can come up with.
it would be helpful for the rubric too, because then we're dealing with one metric.
Yeah, that's what I was going to ask about that clarification. The other thing, so because this is the data call, it only collects information from 11 carriers. So we have to be very mindful not to make it too narrow for plan identification. That's why we aggregated it across all the plans, because there's just not enough variation. And plans that are reporting. So I think we can possibly do that. I do want to look in to see if we're not calling out any plan specifically, if we drill it down to like one plan out of so many plans. And then to realize that we'd still have to probably keep it at the level of all the markets. So it'd be small group, large group, and independent combined to do that, because breaking it out into small, large, or an independent creates too much of a risk for identification. So again, if you're looking at trying to get down to the nitty gritty, we have to also be mindful of not calling out any plan and any possible plan design information for any of those carriers that report to us. So I apologize. I do see John was up first, followed by Michelle, but Vice Chair Burns, did you have anything that you needed to add in, or do you want to give the time to John and Michelle?
Well, I have a suggestion. I can be really fast. I think that there's a way to do this where it wouldn't identify anybody. It would get to what Dan's after and what you're suggesting, Courtney. And it's, you just say, does it have a utilization edit? You can define that as prior authorization or step, or is it non-preferred or not formulary, and lump them all together. And then any drug that didn't hit any one of those categories would be assumed to be on formulary without any kind of utilization edit and restriction, and you just make it binary. And I think that would be pretty clear, because in any of those 4 cases down there, then there's like a barrier, right, for the patient to get the medication one way or the other. Even when it says non-preferred formulary, that's still going to have something on it like a step. And they might be adding, like, counting things twice, because this is a person who's writing yes or no, and they're interpreting it. So I would say per carrier, per drug, do they have any of these 4? If that's a yes, then there's a percentage point in the access issue column.
That's a great recommendation. Thank you, Vice Chair Burns. John, I see your hand up.
It's just an observation of the information that we do have available to us in this table about plan analysis, and just comment that where it is less impediments to receiving care of insulin glargine, it shows in the number up above where Medicaid CCO greatest increase in share and total cost. Well, generally, I would hope that that's a savings to them, even though they're spending more on that particular drug, they're spending less per patient to provide that medication. So the number up above, I don't want to read too much into it, because I think it's a savings to the system all in all.
And Pei, can you go ahead and scroll up to what John was just referring to, into this section here, John, you're saying? Yeah.
Yes, yeah. And then just the blue down below where it's the greatest increase, it doesn't necessarily mean a bad thing.
All right, thanks. Pei, can you go back to the other one, please? Yeah. And Michelle, thank you for waiting.
I was going to make the same suggestion that Vice Chair Burns did. Yeah.
Perfect. Appreciate that. All right. I guess not hearing any other feedback. Thank you for that. I appreciate it. So onto this section, again, this is regarding APAC, annual out-of-pocket cost. Give the board a minute to kind of absorb those numbers and provide any insight for discussion.
So this is calculated without Medicaid.
Thank you, Faye, for clarifying that. Not hearing anything from board members. Think it's safe to continue to scroll pay.
We're on to the clinical reviews. Please stop me if you want me to pause. But I think we can move on to the stakeholders, but I don't think we received anything, regarding insulin glargine. And then,
And this is letters that we received from manufacturers and advocacy groups regarding their information on the glargine drugs. I do definitely encourage board members to make sure that you read the letters. All the letters that will come in from all stakeholders or consumer feedback have been put into the material packets in the appendix. So they're just all there. You just click the exhibit A, B, or C, and it'll kick you out to that. And so you can see what that consumer feedback is as we start building up the material packets. Again, at the Friday, we will take the survey forms offline and conduct the last analysis of any stakeholder feedback that was done through the RFI request since May. We'll provide any updates to the material packets with that. But as we wrap up, is there anything else from board members regarding feedback or information on the glargine review today? And hearing none. Vice Chair Burns, I think I can hand it back over to you. Just a reminder to board members that starting next month, all material packets will be available to review and have discussion on, unless you as board want us to break it out into something else. Otherwise, all of them will be available. I'm just going to kind of have it as an open dialogue to kind of go through each of the drugs. And then if the board wants to start testing, maybe if anything in the rubric is meaningful to help determine if any packets need to be removed prior to January. Otherwise, all packets will be under voting options in January. So,
Okay. Thank you, Courtney. Oh, okay, got a couple. Thank you, Courtney. Thank you, Pei. Thank you, Heather. Chris?
I just had if it's okay to transition back, I want to ask a clarifying question about the rubric. And just many parts of the rubric we tried to make them as objective as possible, Vice Chair Burns. And so it would, I don't know, is it the intent that we're going to go through and give a score for things that are just defined in the packet each individually, or are we going to have something that tells us what the score is for each of those? I mean, how's that process? I know that we can go into the packet and look at, okay, is it 25% or 50% or 75%? But it seems like that leaves it open for errors by the board members to like accidentally take something from a wrong section in the way it's scored potentially. Is it the intent that we are all using it as our own tools if we choose to use it, and we would fill out the score, or is there a way to get some guidance from the staff on certain things that are objective numbers coming out of the reports? Does that make sense what I'm asking, Chair Burns?
I think so. I think you're wondering if we're individually scoring these and then that's tabulated, or if we're looking at this as scoring as a committee, if I'm understanding you correctly.
No, I don't think it's that. I think it's trying to ensure that there's not variation in objective numbers that are in the packet, but in the scoring of each individual board member, I guess. I understand that some parts of it around equity, like there's some subjectivity, and how we weight each thing is subjective in terms of our own personal experiences. But I don't want one board member to make it a 1 if it was actually a 3 just because I looked at the wrong section of a table or misunderstood something in the way the data is in the.
Making sure that we're all looking at the same number. So
that's
if we're voting, if we're looking at X, we're all looking at table 13. Got it. I'm not sure how to answer that, Courtney.
Yeah, I guess the only way I can kind of help shore that up is to create the section that it's most directly associated with, maybe the page or whatever. I'll have to give it a little bit of idea of what that would be. I can present a couple ideas at next board meeting. But again, I think the intention is for the board members to be familiar with the material in the packet and how it associates already with the rubric. And then and during that time prior to the board review, because there's going to be so much information, I would strongly suggest board members utilize all this is posted online, any free time that you may have to really start spending time with the material packets. Once we get those, most of them should be updated and posted within the next week or so. But then you as board members, if you have ideas on how you want the process for the utilization of the rubric to best meet the intention, I'm happy to have a conversation about that. Otherwise, the intent, I will just create some sort of form, send it to all you. You can do your individual identification, but I'll try to make it as clear as possible where that domain section is aligned in the material packet. Is that kind of what you're looking into?
Yeah, I feel like that will be helpful. And also that was going to be my second question is, I know we decided maybe that we're not going to have a public display of the scores and we go through and show what each of ours are, but I would still appreciate getting a copy of the form so that, I could use something like that as I'm going through and not have to have each of us kind of create our own or print out the spreadsheet and use it.
Yeah, I'll just make a generic PDF, a different version without the names or anything associated with it, and send that over to the board. And then I'll just show you what it will look like for next month during our board meeting, and then y'all can guide us from there. Thank you for the questions. And again, board members, as we start wrapping up to this last bit, if you have any suggestions about language critique, a better way to kind of look at the rubric to help ensure a strong conversation for each of the drugs under review, please don't hesitate to reach out to myself or anybody else on the staff to either set up a call or give us an email and we will follow up if we need to. But
Thank you, Courtney.
all so much for your feedback, especially Dr. Hartung, all your time working with the staff over the last, whenever we have conversations, your feedback is really meaningful. And Michelle, welcome, and I look forward to working with you more in the next few weeks. All right, thanks, board member.
Okay. With that, the next board meeting is November 19th at 8 a.m. And if there's no further business before the board, all in favor of adjourning the board meeting, say yes.
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 And any opposed, say no. The meeting is adjourned. It is 11:28. Have a great holiday and Halloween, and I'll see you before Thanksgiving.
Great.
Thank you.
Thanks, everybody.